Halo, selamat pagi kepada seluruh partisipan. Selamat bergabung kembali dengan webinar Akbid Bina Husada Tangerang. Welcome to our third webinar international series. Good morning to all participants and speakers who have joined our third webinar series, Akademi Kebidanan Bina Husada Tangerang. The theme of this webinar is Passion and Lifelong Learning in Midwifery Service. We have held 3 webinars before with an average number of 3,000 to 4,000 participants. This shows the enthusiasm of midwives is in participating the webinars. To obtain SKP Satuan Kredit Poin in Bahasa for STR Surat Tanda Registrasi, Extension Purpose, and of course to gain knowledge. We really hope that this webinar will also be of benefit to health workers in general and especially for midwives. We thank you for your participation in this webinar. Please follow this webinar until the end, so the materials presented by the speakers can be accepted and be useful in the future. The webinar materials will be presented by 3 speakers. Please allow me to introduce the speaker. We welcome to Ms. Kun Lai Chiu, She is a director of nursing Gleneagles Hospital Medini, Johor Bahru from Malaysia. We welcome Miss Mandy Hunter. She is a clinical midwife consultant and midwifery advisor Hunter New England Local Health District, Division of Maternity and Gynecology, New South Wales Health from Australia. And we welcome to Miss Laurencia Lowington. She is a midwife and active in Indonesia Midwives Association Central Board from Indonesia. The moderator for our webinar today is Ms. Rumi Sidabutar, SKM MKM. She is a senior program support specialist, Asian Region Compassion International from Indonesia. Thank you for our great speakers who are willing to take their time out of their busy schedules to be here and share their expertise, which will be very useful to us and will add to our insight and knowledge. Assalamualaikum warahmatullahi wabarakatuh. Peace be with you all. Dear Dr. Ong Chandra MKes SPOG, Consultant Oncology, Advisor of Nur Soraya Foundation. Dear Dr. Maudi E. Ujami, MKF MKEB, Director of Akbid Bina Husada Tangerang, our great speakers, organizing committee, and all webinar participants whom I am afford. Praise the Lord, because of His grace and guidance, we can all join this webinar. I will read the rules of the webinar to all participants. 1. All participants must fill in the attendance link and evaluation link, which will be provided by the committee. 2. The attendance link will be shared for participants who attend Zoom. Participants who take part in the webinar on YouTube channel can fill in the attendance link included in the description box. The schedule for today's webinar is 1. Opening speech. 2. Sing Indonesia Raya song. 3. A welcome and opening speech from Nur Soraya Foundation Advisor. 4. The main event is an international webinar which will be hosted by a moderator. 5. Closing speech. To start our webinar today, let us sing the national anthem, Indonesia Raya. Thank you. Next, we are now going to listen the opening speech delivered by Nur Soraya Foundation Advisor, Dr. Ong Chandra. Hello, good morning, Dr. Ong. Dr. Ong Chandra, selamat pagi dokter, good morning. Masih di unmute dokter?
Oke,
Ya,
Panitia.
oke dokter, pagi.
Selamat pagi. Good morning.
Morning dokter. Dr. Ong Chandra, kami persilakan untuk memberikan kata sambutan sekaligus membuka acara webinar kita. We would like to invite you to give a speech and officially open the webinar. Thank you, dokter. Please, dokter.
Thank you. Good morning for all. It's very dear to speaker, Mrs. Wan Kun Lai Chu, Mrs. Mandi Hunter, and Mrs. Laurenia Lawinoto. Dear leader and employee of Akbid Bina Husada Tangerang as the organizing committee. Dear participants, both midwifery student and midwifery who work in hospital or other healthcare providers. Good morning and welcome. First, let us give thanks to God Almighty. Because of His mercy and grace, we can gather here today to attend the third series of webinar, which is also the very first international webinar held by Akbid Bina Husada Tangerang. This webinar comprised of 3 countries, Indonesia, Malaysia, and Australia. We are grateful for the opportunity to gain valuable insight and knowledge from our speaker, Mr. Wan Kun Lai Chu. He will share about the handling and care of mothers and child during the COVID-19 pandemic. And the second is Mrs. Mandi Hunter. Will share about the woman-centered care in pandemic situation. And then the third is Mrs. Laurencia Lawinoto. Will share about the role of midwife in normal and natural childhood in new normal era. Hopefully, everyone can properly follow this webinar, so the materials conveyed can be understood and implemented in order to improve our health services. Finally, with praise and gratitude to God Almighty, I officially open the third series of Akbid Bina Husada Tangerang webinar today with the theme of patient and lifelong learning in midwifery services. Please enjoy, stay enthusiastic, stay healthy, stay safe and happy. May God bless us all. Thank you.
Thank you, Dr. Ong Chandra, for the opening speech. Terima kasih, Dr. Ong. Our next session is the international webinar event, which will be hosted by our moderator, Ms. Rumi Sidabutar. I will now present her CV. Hello, Ms. Rumi.
Hello.
Yes.
Good morning,
How are you?
everyone. Good. Thank
Yes,
you
let
for
me to
asking.
present your CP, okay?
Sure. Thank you, Miss Erna.
Ms. Rumi Sidabutar has public health background with several professional development in child and community development, has been working with several international NGOs, and now joined with Compassion International Asia region as a senior program specialist for survival and early child health and child protection program. I will hand over this webinar to Ms. Rumi Sidabutar to guide the speakers in giving their respective materials. Please, Ms. Rumi, my friends, my best friends.
Thank you.
Thank you.
Thank you so much, Miss Erna. Selamat pagi, Bapak Ibu, dimanapun berada. I would like also say good morning once again to our respective speakers who already joined with us this morning. And of course, our webinar attendees. Welcome to Passion and Lifelong Learning in Midwifery Service. Thank you so much for taking time out and being here today with us. To our respective speakers and webinar attendees, allow me to use bilingual if I can use that term, bilingual. So I will use English and Indonesian for the entire webinar session to ensure good flow and clear communication happen. Jadi bahasa Inggris dan bahasa Indonesia agak-agak nyampur ya Bapak Ibu ya, nggak apa-apa ya. Well, as mentioned earlier by Ms. Erna, I'm Rumi Sidabutar. We lead our webinar session today. I'm a senior program support of SEC. Itu KIA-nya, kalau di Indonesia kita bilang KIA ya, Kesehatan Ibu dan Anak. Untuk Asia region. Jadi saya bantuin beberapa negara di Asia untuk implementasi kesehatan ibu dan anak. Masih itu aja, itu muter-muter bisnisnya itu aja ya. Jadi I have spent almost 15 years in maternal and child health program with NGO, community groups and families. Jadi agak komplit hari ini kita semua ya Bapak Ibu ya. Mewakili banyak sektor, banyak daerah juga di Indonesia. So we will learn a lot today. Kita mengerjakan fokus yang sama. So today with our great speakers who also have a great experience, we will be looking at following, as mentioned earlier. I'm myself so interested to know deeper, as we stated in started new normal few months ago, and seems to be continued for some period now for new era, pandemic era. So we were looking for the handling and care for mothers and child during a pandemic COVID-19 in Malaysia. So there's some studies and observation in Malaysia, and women-centered care in pandemic era. Role of, and the last is role of midwife in normal natural childbirth in new normal era too. As mentioned earlier by Ms. Erna, this is the third series of international webinar held by ABHT Bina Husada Tangerang. Maybe some of you or most of you, sebagian besar Bapak Ibu juga ikut 2 webinar series yang sebelumnya. Well, yesterday I was informed that today attendees over 2,200, maybe it's almost 200 now, 2,200 people who plan to join. Wow, that's show really good interest and excitement of learning, because we really realize that in our respective areas and our services, there are some challenges to give our best service to community, to families, because of this pandemic. So we will learn a lot today. Okay, so without further ado, I would like to invite our first speaker today, Puan Kun Lai Chu. He has nursing background, holds many development certification, and in 2018 graduated from Master in Business Administration from Wawasan Open University. As we seen in her CV on the screen now, she is a director of nursing in Gleneagles Hospital Medini Johor since 2017. She will be presenting the handling and care of mothers and child during a pandemic COVID-19 in Malaysia. Good morning, Puan Kun. How are you this morning?
Hi, good morning. This is Kun.
Hello.
Thank you.
Yes,
Thank you, Ms. Rumi, for your very kind introduction. Well, I'm actually delighted to be here to join your international webinar with the title Passion and Lifelong Learning in Midwifery Service. Thank you very much indeed. I would like to thank Akademi Kebidanan Bina Husada Tangerang for giving this opportunity. So basically today I will be given about 30 minutes and my topic will be the handling and care of mothers and child during COVID-19 pandemic, especially in Malaysia. So I will start to present my presentation.
Sure.
Thank you very much. Okay, so this is my topic, the handling and care of mother and child during COVID-19 pandemic. Because I'm a Malaysian, so I will talk basically in our country what we do for our people in this pandemic, COVID-19 pandemic time. So this is my outline of the presentation content. where I have an overview on the COVID-19 pandemic in Malaysia, and I will talk a bit about our statistic as at 19 October. As you know that our country, suddenly our COVID-19 numbers shoot up recently for the past 2 weeks. And I will talk a bit about guideline on COVID-19 management in Malaysia and understand a bit about COVID-19. And I will continue to talk about clinical monitoring for adult COVID-19 patient, and I will go into for child as well for the COVID-19 patient. Then I will also touch a bit about pregnancy and also neonate. Then I will conclude my session in 30 minutes time. Okay, so let's look at the first one in overview. As you are aware that the pandemic of COVID-19 is started beginning of this year. And the first case of the COVID-19 occurred in Malaysia was actually in January 24, early of this year. And we have early February, our government and Ministry of Health has already started to have some strategy in order to overcome this pandemic, COVID-19 in Malaysia. So 57 hospitals provide screening service and 26 government hospitals responsible for the care of COVID-19 suspected patient. So we have the religious gathering in KL on the 27th February to 1st of March. That was actually, we have some patient from there onwards. So the situation became quite worse from 11th of March onwards. And because of this, our government has addressed the issue. Then the whole country lockdown started on 18th of March. And our first 2 deaths happened on the 17th of March. Then Ministry of Health in Malaysia has taken some steps to contain the spread. Okay, one of those is to using the thermal scanner to check temperature for every area where the people moving around, and increased number of hospitals that could treat COVID-19 patients. And they also have COVID-19 funds to raise money and channel to the patient, especially those who are affected financially due to the quarantine procedure. And we also set up a provisional hospital in Serdang. This is where somewhere near our capital, Kuala Lumpur. So we have all the patients who actually confirm COVID-19 is actually all centralized in that hospital. So we look at the statistic in Malaysia, where we have recently, if you can see from here, from September 1st to October, we actually have some increase number in COVID-19 patient, and this is due to movement of the patient who actually affected. So now in our country, actually government is looking into this in a very serious matter. And if you can see from here, this is our map, as Malaysia is actually consists of Semenanjung, Malaysia, and the other one is Sabah, Sarawak. As you can see, Sabah is our red zone, and also Perak. These two areas are the one that actually our government is focused on, and actually at this moment they also have some control movement order in place. Then we talk about guidelines of this COVID-19 management in Malaysia. Because of this COVID-19, Malaysia Ministry of Health actually came out with total of 42 annex. And today's topic, because we are talking about mother and child, so we chosen the annex which is related to mother and child aspect. So we will talk about that in the next slide. Okay, first of all, I just go through with all of you about the COVID-19. Okay, as you know that the COVID-19, the common symptoms include fever, dry cough, sore throat, and then also difficulty in breathing. So other symptoms include tiredness, aches and pains and nasal congestion, headache, conjunctivitis, diarrhea, loss of taste or smell, or a rash on the skin or discoloration of the fingers or toe. So all these actually are the symptoms of the COVID-19. And the first one actually is fever. That's why we have all these temperature taking wherever you go in this country, regardless if it's a hospital or the shopping mall or the restaurant, etc. And 1 out of 5 people who get COVID-19 become seriously ill, and they will develop difficulty in breathing. So how is the transmission happen is actually mainly by droplets from someone with COVID-19 who cough or sneeze or speaks within a distance of 1 meter. So the droplet, which contains surface and object, is by touching, and contaminated surface or object, and then they will then touch their ears, their nose, their eyes, and the mouth. All these will be spread, and the symptoms will be spread from one to another. So the incubation period is actually estimated to range about 2 to 14 days. So during this period, you are actually highly will be infected by the COVID-19. Okay, let me go into the adult COVID-19 patient. How are we actually monitor them? Okay, in our classification, we actually classified the COVID-19 patient into 5 categories. This is asymptomatic. Second one is symptomatic without pneumonia. The third one is pneumonia, but they not require any oxygen. And number 4 is pneumonia, but they require oxygen. And number 5 is critically ill patient. So for number 1 is actually asymptomatic. These patients are actually, they are a bit light. So what we do is we will monitor their vital sign twice a day, and the doctor will review the patient twice a day. Then we have some laboratory checking, for example, FBC, RP, LFT, and RBS at the baseline, and then they will repeat the blood whenever necessary. And then they will have the chest X-ray at the first presentation as well. So this is the first category. Second category is symptomatic, but they do not have any pneumonia. So the vital signs monitoring will be 3 times a day, and then the doctor will review the patient. So we will have all the blood at first category as a baseline. Then they will also monitor their bi-weekly on their rest, repeat, and then if the patient is having some risk factor. Then they also have chest X-ray, and if let's say patients show any warning sign, they will actually repeat the chest X-ray immediately. This is the second category. And then we have third category. This patient, they are pneumonia, but they still can breathe quite okay, then they don't need oxygen. So this kind of patient, they will classify as category 2. However, in the presence of risk factor vital sign, they will monitor the vital sign 6 to 8 hourly. So if further clinical deterioration, they will increase the frequency of the monitoring. So as usual, they will have all the blood tests and also the ECG for the patient and also chest X-ray. And category number 4 is pneumonia requiring oxygen. So this kind of patient, we will assess individually. In case you need, they will refer the patient to ICU, and then they will monitor the vital signs 4 hourly and also hourly. Depends on the situation of the patient. Then they will also have all these blood tests and also chest X-ray, ECG in place. And number 5 is actually will come into the most serious category. This is critically ill patient. So they will have to admit the patient in the ICU, then according to the ICU monitoring protocol that's stated by our Ministry of Health. For this is adult. So let's come to see the child. The child, basically, they also divided into 5 categories. It's more or less the same like adult. So for clinical stages 1 and 2, they consider as mild disease. So either they are asymptomatic or they are symptomatic, but they are not pneumonia. So what they do is they will test positive, they will test RT-PCR, and then they will have some upper respiratory tract symptoms, for example, like pharyngeal congestion, sore throat, cough, or fever for a period less than 7 days. Then they come to the third category. So we have the moderate disease. Either this patient actually they are symptomatic, but they're actually having pneumonia. So they have some of the symptoms, and with others also, for example, like vomiting, diarrhea, abdominal pain, myalgia, loss of smell and taste, and signs of increased work of breathing and increased respiratory rate, but there's no hypoxemia. That means no oxygen is required. So they are still okay, but it's only you have to really look at their breathing pattern and then to prevent them to go into the worst stage. So stage number 4 is talking about a severe disease. So this kind of category patient will symptomatic, and they are actually go into pneumonia, and they're requiring supplement of the oxygen, and they may go into non-invasive or invasive ventilator. So what they will have is like tachypnea and with hypoxemia on the room air. And then your CNS will be affected. They will appear to be very lethargic and then decreased level of consciousness. And sometimes even they go into fits because of the oxygen level is low. Then they have GI tract effect, for example, dehydration, difficulty in feeding, raised liver enzymes, and myocardial effect. So they will raise creatinine, kinase, and troponin. And come to the last stage is actually a very serious and critical illness, where critically ill with multi-organ involve the new or increased need of invasive or non-invasive ventilator. They will go into sepsis. They might go into multi-organ failure and rapidly worsen in the clinical disease. So they will have rapid disease progression with respiratory failure that requiring mechanical ventilation support. And they actually persistent, they will have hypoxemia, and then eventually they will develop septic shock and organ failure, which really needs a lot of support from the ventilator. So this is basically the child, but the difference of adult and child is because child is very fast, they can come into respiratory distress syndrome. So when nurses look after the child, they have to be very alert with the child's situation and be progress. So general care for patient with the child with COVID-19. First one is usually we talking about the fever. We do not want the patient to experience continuously fever. So it's antipyretic medication will be given to the patient. And then they will also talk about oxygen supplement. So they actually use low flow nasal cannula oxygen. And if the children, they are still hypoxic, they will give a high flow nasal cannula. And sometimes they also want the patient to be nursed in the negative pressure isolation room. Routine blood gas is not necessary. And for the feeding, nasogastric feeding or intravenous hydration started when the child is unable to tolerate all these oral feeds. So we do not actually want the patient to experience dehydration situation. And avoid aggressive fluid management, which can impair alveoli oxygen exchange. So when the doctor plan the treatment, they have to be very careful and strike a balance in this area. And we have to avoid using of the nebulizer. So when B2 agonist is needed, deliver through spacer by using metered dose inhaler. And in critical cases in stage 5, then additional pressure and ventilation support may be required, including intubation. So intubation should be performed by the most experienced provider with appropriate personal protective equipment in place. This is what we stress a lot in our COVID-19 management. Okay, so I will bring your attention to the management of COVID-19 in pregnancy. So all the frontline ONG staff, we should be trained in donning and doffing of PPE because we are nursing the pregnant mother with COVID-19. And then the screening of the PUI shall be done as per our Ministry of Health guideline. And all the designated ONG hospital will establish a dedicated core team who are responsible for the management of COVID-19 in pregnancy. So the pregnancy team, they actually will know how to handle the pregnant lady. And then whenever they go into stress, they will initiate all these emergency Caesar, that kind of thing. So they are actually very well trained. And the mother and baby friendly policy for the PUI at the designated hospital are suspended to reduce the risk of exposure. So we do not actually encourage baby friendly at this moment. And then designated hospital should have the identify labor room to manage PUI and confirm patient. Designated hospital shall also have an identify operation theatre to manage the PUI. So this one, they will have to find ways so that they will not contaminate the whole operating theatre. And non-vaccinated hospitals should identify a specific labor suite and operating theatre to manage PUI. And in the event of requiring a surgical intervention, regional anesthesia is preferred instead of GA, because we prefer to do it in the local induction, and we prefer to do it in the negative pressure room. Patient in labor should be offered a cesarean section if the mode of the delivery and it's not well defined. Okay, so they have to prepare the patient in case they cannot go into normal deliveries, then they have to go into Caesar. And then handling of the body fluid specimen, including placenta and the patient apparatus, shall be handled based on the standard universal precaution in the individual hospital. And then breastfeeding should ideally be deferred until confirmatory diagnosis exclude COVID-19 infection in the mother. So breastfeeding will not be encouraged at this moment for the pregnant lady and after the patient is delivered. Okay, so for the patient after delivered, the management of the COVID-19 in the neonate. So neonate born to the mothers who are PUI or confirmed COVID-19 infection between 14 days before delivery and 28 days after delivery. This is the definition. And neonates directly exposed to those who are PUI or confirmed COVID-19 infection, including family members, caregivers, and also medical staff and visitors. The neonate should not receive breastfeeding or breast milk until the mother has been confirmed to be negative of the COVID-19. If the mother is still keen on breastfeeding prior to confirmation of the COVID-19 infection, so it should be documented in the clinical notes that the mother wants to do it, even though we have given them the counseling session. Okay, for neonate, upper airway specimen should be collected and tested every 72 hours until 2 consecutive specimens is showed negative for COVID-19. So after that, then they will be free of COVID-19 in the neonate. And the discharge criteria will be upper airway specimen. And they are negative for the COVID-19, 2 consecutive specimens. And the neonate must be monitored under the home surveillance until the day 28 of life. So the conclusion will be, okay, at this pandemic area, actually all of us are at risk. And also we be very high alert with the patient around us. So in our hospital, we actually emphasize a lot to do with universal precaution. And it is compulsory that we need to wear the mask. And hand hygiene is highly monitored. And we also have our hand hygiene percentage, and we have auditor around to see our staff, what they are doing. And then social distancing is one of those, because we want the staff to be very alert in this and to be alert around the patients, around the colleagues. And we believe that with all these in place, we will be able to combat the transmission of the COVID-19 from one to another. This is a hospital where I work, Grand Eagles Medini Hospital in Johor Bahru. This is next to Singapore. Actually, we have a very active infection control committee meeting ever since the pandemic is started in the beginning of the year. So we have all the infection control measures in place. And this is the one of the photo to show that this is the entrance. We have all the checking at the entrance for asking the patient what are the purpose that they come to the hospital, and then they also have to pass their temperature checking. So if let's say they are fever and they're suspected to have contacted some of the patient around, then they will be nursed in another fever bay, and from there we will take very, very serious precaution and also measures to make sure that our screening is effective. So far, so good. And in Malaysia, I just want to share with all of you is, in Malaysia, all the COVID-19 patients, we actually will nurse in the government sector. So private sector, in case we have the suspected PUI patient, we will contact the government sector, then we will send our patient to them. So from there, we will nurse the patient according to the COVID-19 guideline. Okay, so I will conclude my presentation. Thank you very much.
Thank you, Ms. Kun Lai Chu. I think you saved 10 minutes from time presentation. That's great. We will save it. Or is there anything that you want to share as an addition? Because you still have 10 minutes.
Oh, okay.
Is that okay?
Maybe I just share about our hospital. How phobia are we when we actually come to this pandemic 19? There was actually way back to January when we actually admitted some of the patient fever, and I think because of the Wuhan outbreak of the COVID-19 pandemic. So we have actually ad hoc meeting with our person in charge of the hospital and also the infection control committee. So we actually have very regular meeting and also intensive meeting to protect our hospital, not only our colleagues and also our patient. How are we going to prevent people and also the COVID-19 patient come to the hospital? So in the management of the ward, actually we have come into to scan patient when we have a screener. We scan patient at the screener side, and if let's say they are fever, they will come to the fever bay. So we set up a fever bay, and we have a designated staff to look after the fever bay. Then we also have the rescue bay to receive the patient from the fever bay so that we can segregate them into highly suspected COVID patient. We actually use the COVID test. The time we actually, our doctors would like to have a COVID test, RT-PCR. RT-PCR is actually a golden rules for diagnosis of the COVID-19. So the patient who is highly suspected, we will use that as a baseline kind of like diagnosis. So far, we have come across a few patients who are actually positive in our RT-PCR. So we actually send them across to the government side. Then in the in-house management of the ward, we also set up a PUI ward for those highly suspected patients, meaning that you are fever, but we have not got your result yet. So we will nurse you in that particular ward. So that particular ward is totally like an isolation ward, and all the staff, they are actually well trained in the PPE donning and doffing, and also we have given them the scrub suit, and they have to follow that kind of like infection control guideline, so that when they come to work, they have to take temperature, they nurse the patient, and the patient is actually individual room. We do not mix the patient. We have the patient in that particular room, individual single room. So after duty they have completed, they actually they also have take bath. Make sure they take their bath before they go home, so that they can actually do something like to protect themselves and their family. Apart from that, we also initiate our code blue drill in this kind of ward, because we need to wear that kind of like PPE, and also we have a procedure to deal with all these patients. So far, we have admitted some of the patients, but they are I mean, after checking, they actually come into quite safe situation. And before we go to operation, we have to do the RT-PCR test, because we want to make sure that the patient comes into the operation theater would have screen, so that our theater is well protected. So for the patient who are going for delivery, we actually, the husband, if let's say they want to accompany the mother, the wife for delivery, then the husband also need to be scanned and also need to do the screening. So to make sure that our labor ward is actually very safe for the usage of the public and also our staff. So for this period, actually the husband who requests to go into the operation theater to observe the LSCS is not encouraged at all. So basically they can understand and they can have the cooperation with our people and our doctors as well. Yeah. So in our delivery suite, actually we got 4. So we have actually also identified one of the delivery suite to be given to this kind of patient who suspected fever. And let's say they also fit into that kind of criteria, got a bit of sesama, that kind of thing. So we will actually nurse them in that particular delivery suite as well. Yeah, this is what we do in order to make our environment safe and good as well. Yeah. So now, the latest initiative that we have is all the patient admit to the hospital, we will do the COVID test before you come to the admission. So the COVID test will be two types. One is RT-PCR, the other one is antigen. So for all these a bit lighter case, they will have antigen, but for operation cases, all these we still fix to our golden rules as RT-PCR. Yeah, this is what we are doing at this moment. And it's compulsory for our staff to take temperature when you come to work and before you go back from your work. This is what we're having at this moment. Yeah. We are very, very well aware of this, and also our government also have an initiative to have that kind of apps with us. Wherever you go, it will be traceable. This is called My Sejahtera apps. So this one, wherever you go, we have to use our QR scanner to scan the code. This is one of the initiatives that our government is doing at this moment. Yeah.
Thank you for the addition. That's a very good practices. And I think we can learn a lot, and then we can compare also with other hospital or areas. So we can take some that we suggest to be in our services. Ms. Kun, I just want to make sure that you will stay with us for the entire webinar, correct? Because there is a okay. In an hour we will have Q&A sessions. So participants will give you a lot of questions. Trust me. So, wait for us, okay? Thank you so much. What is interesting for me is the process is very thorough, and then there are the patient's mother and also the child treated based on their stage. That's very interesting. Yes. So yes,
really close monitoring of the patient and really the appropriate treatment to the patient as well.
Yeah. Yes, thank you so much for Juan Kun Lai Chu. We will go to our next speaker today. Our next speaker is from different continent. Come a long way virtual, but virtual. From New South Wales, Australia. She is Miss Mandy Hunter, will be presenting women-centered care in pandemic area. I would welcome Miss Hunter.
Good
morning.
Good morning.
Hi. How are you?
Very well. How are you?
Thank you for joining us.
Can you hear me?
Your voice is kind of bumpy.
Oh, is it?
Yeah, you're dropping. You
slowly.
Let's try. Okay, can you hear me well?
I can hear you well. Yes.
Okay, let's check. Well, I would remind you if like your voice dropping like that. So later we just want to go through. But if I just check on me once a while, okay. Maybe your voice is dropping or the. Sure.
Anytime.
So what time is it now there in South Wales? In your place?
1:45 in the afternoon.
I see. So that's still morning then?
No, 1:45 in the afternoon. We're 4 hours ahead of you.
Afternoon. Oh, I see. Yes. Okay. So that's over lunch for you. Correct?
Yes.
We just had our breakfast and you just had your lunch. Yes. So let me check for maybe Ibu Erna. Can you hear Mandy well? Bu Erna or
Yeah.
Ibu Modi? Can you hear Mandy's
Can
well?
you speak a little so we can make sure that your voice is okay?
Okay, can you hear me now?
I can hear you clearly, Mbak Rumi. In my place, that's okay.
That's okay. I just want to check so
Yeah.
our
Okay.
attendees also. Okay,
How about you,
so
Bu Erna?
Miss Maudi voice is clear, but Mandy not so clear.
Can you see my presentation?
Oh, we have your presentation, Mandy. We
Oh,
can
that-
help to share for admin in this webinar.
Or maybe you have adjust your microphone volume for.
I think I don't know that I can turn it up anymore. That's as far as I can go.
let's try, I think. Can we
Okay.
try?
Okay, I'll try.
Yeah.
Okay.
So you will
you can see my
have
presentation.
yes. So Ibu Erna, who's going to share the presentation? Is it ready?
It's on. I've got it on the screen. Can you see it?
Sabrina.
We read the CV Mandy first, Rumi.
Can you see it now? Oops.
Yes, please, Sarah. I will introduce you first, Mandy. Yeah. So, yes, our next speaker is Mandy, Miss Mandy Hunter. So she is a clinical midwife consultant and midwifery advisor, Hunter New England Local Health District Division of Maternity and Gynecology New South Wales. She has midwifery background and in 2015 graduated from Praxis Online Ethics Training course Monash University. She published some research publications, you can see in the CV, that later you might want to check. She also is a finalist Hunter New England Quality Awards in dextrose gel for treatment of newborn hypoglycemia. So I will give 30 minutes for Mandy Hunter to present her presentation today.
Thank you.
Over to you, Mandy.
Thank you. Selamat siang.
Selamat siang.
And thank you, Moody, for inviting me to come and present to you all. I saw that there was over 300 participants today. That is phenomenal. Well done to the organising committee who put this conference together. Congratulations. So I thought I would start by telling you a bit about me, just quickly. I've been a midwife for over 20 years, and before that I was a nurse. I was born in Scotland, not Australia, and I came to Australia when I was 8. This photo is my family, and I took them back to Scotland in 2014. I've been married for over 30 years to the bearded one on the right and had 4 children. I just want to clarify that I wrote this presentation a month ago, and I've been on holidays. I actually got back today, so the data is just a little bit. The data is about a month behind. So I wanted to give you some context. We have 6 states and 2 territories in Australia. Most of you will know. It's a big country. I did my training over here in Perth on the left side of the screen, and I ended up in Newcastle here on the right side of the screen just over 20 years ago. I'm living in Newcastle, which is 2 hours north of Sydney. Hunter, New England. I'm sorry. Hope that the scale is right through there. been a consultant for the last 8 years, but prior to that, my passion was birth suite, and I spent a long time working in the birth suite and being a clinical educator. So I wanted to just give you a bit of an idea of the size of our district. In actual fact, it's about the size of Java. If you look at the square kilometres, Java is 128,000 square kilometres. New England, our district, which is the largest district in New South Wales, is about 131,000 square kilometres. Now, New South Wales is our most populated state in Australia. But you can see that we've only got about 920,000 people in that district, compared to 141 million in Java. So we are vastly different. We have a large, geographically sort of isolated population in our district compared to Java, which I believe the city, Tangerine, was one of the most populated cities in the world a few years ago. So Newcastle would probably feel like a small, quiet town to you. It's certainly smaller than our two capital cities, Sydney and Melbourne, but it's actually quite a large city for Australia. About half of our population, 450,000 people, live in and around Newcastle down here, and the rest is spread out over the district. As I'm sure Moody would attest to, Newcastle is a beautiful city. It's popular for speech culture. Whales can be seen migrating along the coast in June and September. We're close to the Hunter Valley, which is a wine region, and the John Hunter Hospital, which is where I have predominantly worked, is the only tertiary referral hospital in New South Wales, which is outside of the Sydney metropolitan area. So we cover a very large geographical distance. So by way of background, Hunter New England has 13 maternity hospitals across our district, and we have about 9,000 babies born every year in Hunter New England. John Hunter, as I said, is the only tertiary referral hospital, and half of the babies in our district are born in John Hunter Hospital. And we have about 11 to 12 babies born every day. For us, this is a very busy day, but I can imagine for some of you, that's not so busy. We have a maternal fetal medicine unit that looks after women with complicated pregnancies, and any woman that births under 34 weeks will birth at the John Hunter Hospital, because that's where we have our facilities. So women with medical disease, babies with congenital abnormalities and multiple pregnancies, they will come to us to have their babies. So we have 4 regional hospitals across the district. They're various sizes. They all have obstetricians and paediatricians on call 24 hours a day, and they're usually staffed by junior doctors and midwives. They take women with moderate complications in pregnancy from 34 weeks, but their resources are quite limited compared to a tertiary hospital. And any women and babies under 34 weeks or with complications will have to get transported to Newcastle, which can take between 5 hours by road or 2 hours by air. As well as our 4 regional hospitals, we have 8 district hospitals, and they're smaller GP-led units across the country, and they range from about 45 to 150 births a year. So not a lot of babies being born in some of those hospitals, maybe up to 3 a week. These units are often quite a long distance from the next higher level maternity service, and that's really important when you're considering the risk to mothers and babies. If a woman or a baby has complications that needs transfer, this could take anywhere from 40 minutes to 3 hours. That's a long time. Transfer transferring women and babies from the top of our district to John Hunter in Newcastle can take 6 hours.
Hi, Mandy.
Hello.
Mandy, I'm so sorry. Yeah,
Yes.
hello. I'm so sorry. I think I to interrupting you. Your voice kind of bumpy on and off.
Yes.
So I'm not sure how we can fix this. Maybe the microphone, because we want to hear everything. We want to make
Okay.
sure that we understand your presentation. Well, I think it might be the external microphone or the
Let me-
position.
Let me take my earphone off and see if that helps. Can you speak now?
Yeah, it's better.
Is that better?
Can you speak more?
Is that better if I speak like that?
Yeah,
better, Mandy.
it's clearer.
Clear.
So,
Okay, all right. I'll sit over next to this. Okay.
yes.
All right.
Okay. Can we back to like 3 slides before?
Okay. Oh, you
Is that
sure?
okay? I'm so sorry for asking you this, but yes, 3 slides.
This one,
3
or you don't need to hear about me again. This one.
Correct. Yes.
Okay.
Yes.
All right.
Yeah. Okay. Thank you, Mandy.
So I put this slide together, and the scale might not be perfect, but it's fairly similar. And it's just to give you a bit of an idea of where we are. I am in that red spot there down in New South Wales, compared to Java. So Perth is on the other side of Australia. That's where I did my midwifery training. And now I'm over in Hunter, New England, which, as you can see, is just near Sydney. So, according to my research, just to give you an idea, Hunter, New England is actually about the same size as Java. So Java's 128,000 square kilometres, and we're about 131,000 square kilometres. So Newcastle is the biggest metropolitan city in Australia. But as you can appreciate, it's vastly different from Tangerine, which I believe is one of your most populated cities in the world. It was one of the most populated cities in the world. Newcastle would feel like a small, quiet town to you, but it's actually a reasonably large town in Australia, not quite as big as our capital cities. So by comparison, on Java, you have 141 million people, whereas Hunter, New England, which is slightly bigger, doesn't even have 1 million. It has 920,000 people. And half of those people live in and around Newcastle. So as Moody can testify to, Newcastle is a very beautiful city. It's popular for its beach culture. The whales can be seen migrating along the coast in June and September. We're close to a wine region, the Hunter Valley. And we have John Hunter, which is the only tertiary referral hospital in New South Wales outside of Sydney. So we cover a very large geographical area. So Hunter, New England has 13 maternity services. We have the big John Hunter Hospital, which has about 4,000 births a year. And that's just about half of all our babies. We have about 9,000 babies born every year in Hunter, New England. In John Hunter, they have 4,000, as I said, which is about 11 to 12 babies a year. And for us, that's a busy day. We have a maternal fetal medicine unit that looks after women with complicated pregnancies. Women who birth before 34 weeks all come to John Hunter Hospital. Women with complicated medical diseases, babies with congenital abnormalities and multiple pregnancies, they will all come down to Newcastle to have their babies. We have a large neonatal intensive care unit at John Hunter. There are 4 regional hospitals of various sizes, and they all have obstetricians and paediatricians on call 24 hours a day, and they're usually staffed by junior doctors and midwives. They take women with moderate complications from 34 weeks pregnant, but their resources are limited, so they often need to transfer women and or babies to John Hunter in Newcastle, which can take between 5 hours by road or 2 hours by air. So we have 8 very small district hospitals in Hunter, New England, and they're GP-led units, and they range from about 45 to 150 births a year, or maybe 1 to 3 babies every week. So these units are often a fair distance from the next level maternity unit, and this is very important when considering the risk to mothers and babies. So if a woman or a baby has complications that need transfer of care, it can take anywhere from 40 minutes to over 3 hours by road. So transferring women and babies from the top of our district, so the very top in John Hunter to Newcastle, can take 6 hours by road. That's not always possible to transport. It's not always possible to transport women by plane. And we only use the helicopters there for newborn babies. So GP-led hospitals care for women with uncomplicated pregnancies from 36 weeks gestation, and they don't have any neonatal facilities or paediatricians. They often only have 1 midwife working per shift, and the GP's on call. So that's a little bit of background for you when I talk about COVID in New South Wales. So compared to most countries in the world, Australia has been extremely fortunate with our experience so far with COVID. We've been very lucky. Our first confirmed case in Australia was on the 25th of January in Victoria, and the numbers were very slow to rise. And that's because most new cases in the first wave were returned travellers, and our quarantining strategies were initially very effective. At the beginning of March, I would have to say that many of us felt that Australia were going to be lucky and not really be affected at all. However, by mid-March, our concern was starting to rise. The news from China was very bad, and Italy was in big trouble, with over 250 people a day dying. By the time the Ruby Princess docked in New South Wales, that's that big cruise liner that you can see in front of the Sydney Opera House, by the time it docked on the 19th of March, we still had less than 100 cases across New South Wales, but we were starting to mobilise and make preparations. The Ruby Princess changed everything. They disembarked 2,700 passengers, and subsequently more than 369 passengers and 140 crew tested positive. This made it the first big source of infection in Australia, and it was subsequently linked to 700 cases of COVID and 21 deaths. The day after the Ruby Princess docked, Australia closed all its borders to non-residents. And on the 21st of March, they brought in all their social distancing laws and closed all non-essential services. So we had a very quick response after the ship docked. Oops. Oh, hang on. There you go. By late March, Australia was seeing about 350 cases a day, and Hunter, New England was close to having 100 confirmed cases across our district. We have a very good public health service in Hunter, New England, and they started to prepare for the worst. They looked at their modelling predictions showed us that in Hunter, New England, on the 25th of March, we had 100 cases. Their modelling prediction showed us that with a 3.5 per day doubling, we could expect 25,000 cases within the month. If you looked at 4% of those people going to ICU, we could expect to have over 1,000 admissions to intensive care within a month. We were very concerned about that as a district because we didn't have anywhere near the facilities to cope with that. We knew that we had to flatten that curve of disease projection, because the ICU beds would far exceed that requirement would far exceed our bed capacity. So it was about this time that we all started to prepare in earnest. So our district had a strategy to manage COVID. Each of our hospitals had a whole of hospital response. Every one of the hospitals had to have a coordinated screening area on entry. They were mobilised to arrange waiting rooms and consulting rooms with safe seating and with seating and safe spacing. We had designated COVID areas, wards and teams of staff across the district. We did it in a, and I'm not sure if you've done this in Indonesia, we did it in a, it was coloured, so green areas were COVID-free, orange areas COVID suspected, and red wards were for COVID positive. We implemented a number of strategies to reduce waiting time for patients. For example, our diabetic clinic replaced the face-to-face education with online education. We restricted all visitors into the hospital and allowed one designated person only per admission. And this was very difficult for us in maternity, where we realised how important it was to have families around women when they're having their babies. There was coordinated procurement of PPE, personal protective equipment, and additional equipment, because initially across the country we faced a huge shortage of face masks and hand gel. In fact, one of our local breweries changed from making beer to making hand gel, and they did that very successfully. Staff health was a big concern. Each year our hospitals suffer from increased sick leave over the flu season, and we were very worried that as the COVID numbers increased, we wouldn't have enough nurses and midwives and doctors to care for our patients. So one of our most important early strategies was to promote the flu vaccination, and we had our greatest uptake this year. Consequently, we had our lowest rate of sick leave for many years. In the early days, there was restrictions on the number of student nurses, midwives and doctors who could attend placement. And this was a real concern for us, as we know, as we were concerned about our ability to generate new workforce, which we rely on each year with new graduate recruits. So we did some work on preparing for the employment of new staff to reinforce our workforce. So we recruited a number of student nurses and midwives on a casual basis, and they were trained to man all our screening areas and put on a pool of staff that we could call on if we need to, if our wards became inundated. So I'll talk now specifically about maternity care, and the effect of COVID on pregnant women. So early advice from China, UK and USA was that pregnant women were not more susceptible to consequences of COVID than the general population. But bearing in mind that a tertiary referral centre takes the sickest pregnant women, we knew that we had to prepare for that at John Hunter. We knew that there was minimal risk of vertical transmission, but there was a small increased risk of preterm birth, and that was going to potentially affect the tertiary referral hospital. Women were strongly advised to minimise their risk of exposure, and if they're in contact with COVID, to self-isolate and stay away from the hospital unless they needed urgent care. So that brings me to women-centred care. And women-centred care, our aim in Australia is to provide women-centred care. And I hear that it's something you're familiar with. I'll just touch over the principles again. Providing women-centred care is about providing transparent, individualised, respectful and responsive care. It recognises a woman's right to be in control of decisions for herself and her baby and her family. So providing choice is key to providing women-centred care. Care needs to be flexible, evidence-based, and it's care that's wanted and needed and provided at a time when it's wanted and needed. We're very passionate about this in Australia, And as midwives, we advocate to having no exceptions for women-centred care. Unfortunately, we needed to change the way we provided care in Australia, basically to protect our staff, our women and babies and families. So instead of putting the needs of individuals first, we had to create a system where we were less focused on individuals and more focused on the greater good of all. And this effectively took choice away from women, which was something that didn't really come easy to us. It contradicted our philosophy of care in many ways. So, for example, to minimise the traffic in the hospital, which was important for decreasing spread, we imposed many restrictions on visitors, and this was very upsetting for women and their families. A woman coming in for an ultrasound, for example, into maternal fetal medicine, had to come without a partner. And if she was given bad news about the results of that scan, that was very upsetting for her family, and also for the staff who were caring for her. We reduced the number of routine antenatal visits. The challenge here was to identify, of all the things we routinely did, what needed to go. We optimised telehealth services and off-site clinics. We imposed physical distancing rules and stringent infection control measures. And as for the evidence, which is key to women-centred care, we knew that we had very limited evidence. What we knew about COVID changed frequently, especially in the first wave. And an example of that was breastfeeding. So we were very concerned as midwives about the initial advice regarding breastfeeding, and I won't call it evidence, it was advice, which suggested that breastfeeding increased the risk of transmission of infection, whereas we know instinctively how important breastfeeding is as a protective measure for babies. So it was important for us as leaders in healthcare to come together and create guidance for women and staff and communities. As a district with responsibility for a network of 13 hospitals, we needed an approach that would support all our smaller country hospitals as well. So nationally across Australia, there was huge concern about COVID reaching our small isolated communities where they have very limited resources, and where our population of Aboriginal and Torres Strait Islander people is much higher, and they are of course much more susceptible to chronic disease. So we needed to introduce strategies to keep our 8 smaller GP-led maternity services COVID-free. They have a limited workforce of doctors, nurses and midwives on each shift. For example, there might be only 1 registered nurse a shift and maybe 1 or 2 doctors in the community. So if staff contracted COVID out in our smaller units, we may have to close an entire hospital, and that was a big concern for us. So we needed to communicate with hospital staff in larger hospitals about the need to accept transfers of women with possible or confirmed COVID if that happened. And this meant having processes for planned and unplanned maternity presentations. For example, women booked for planned caesarean section who had COVID would either be delayed or arranged for birth at a larger hospital. Women who presented with pregnancy complications or labour with suspected or confirmed COVID would need arrangements made for emergency transfer if time permitted. This is just an example of the first lot of guidance that we produced in the early days back in March. Probably the most important role that I had at the time. I led the development of this guideline with our district obstetrician to create a network response. Basically, the information, the flowchart on page 2 sums it up, and you can have a look at that later. And to bring this together, we had to consult many different resources, and we were mindful that the evidence for what we were recommending was not necessarily sound. We just had to, you know, use our best judgment when we were sifting through the advice that was coming from across the world. So our first version of this document was in March, and we're now up to version 5, because as you can appreciate, things change all the time. The case definition is a classic example, and I've lost count of how many times infectious diseases have changed the actual case definition for COVID. So keeping up with the latest evidence and advice wasn't easy because, as I said, it was changing rapidly. So what New South Wales Health did was they formed what we called communities of practice. Basically, all of our midwifery and obstetric leads, including me, from around New South Wales, meet regularly by Skype or Zoom to discuss issues relating to COVID and what our state guidance was going to be. Initially, we held these meetings every fortnight, then every month, and now we're meeting every second month. And this helps to inform what we do at a state level, a district level, right down to the hospital level. And I've included the latest advice as resources for you throughout the presentation. This is an example of the antenatal advice that we have, as a community of practice, agreed on across New South Wales Health, and I won't go through it. I'll talk about antenatal care. So we made significant changes to antenatal care across New South Wales. In Australia, we have a recommended schedule of antenatal visits that range from between 7 to 10 per woman, depending on risk. So COVID care restricted us to essential elements of safe maternity care. So we had to agree as a community of practice on what we needed to keep and what we could afford to go, because we wanted to minimise women's presentations to hospitals and clinics, and therefore potentially limit the spread of the disease. So we cut it right back to 5 visits: a first visit, a booking in visit, a visit at 20 weeks over the phone, a face-to-face visit at 28 weeks and at 36 weeks and at 40 to 41 weeks. And that was it. We also limited the contact time to 15 minutes per visit. In Australia, a normal midwifery appointment usually takes about half an hour. That's accepting the first visit, which I'll talk about in a minute. So all women were screened over the phone before they arrived for their appointment. They all got a phone call to ask about whether they'd had a temperature or had been in contact with anyone who was known to have COVID. And if they screened positive, then different arrangements were made and we didn't bring them into hospital. We redirected all low-risk clinics to the community. So instead of women coming into a busy hospital, we opened up community clinics out in the suburbs, and the midwives went out there and did the visits out there. I'm going to talk a bit about parenting education in a minute, but we effectively closed all face-to-face parenting education classes. We stopped all partners and support people coming to any face-to-face visits. Again, I can't stress enough how much this did not sit with our philosophy of women-centred care, but it was something we knew that we had to do and we had to get right. What we know since then is that we've had, this has increased our ability to attend domestic and family violence screening. I'm not sure if you do that in Indonesia, but we screen all women for domestic and family violence. And what we found was that we could never do that when a woman presented with a partner. We would defer it. But because they were coming alone, we were able to do more screening, and we had a 33% increase in domestic family violence reporting in Newcastle during this time. We're not sure if that's because there was an increase in domestic and family violence, or if it was because we were able to screen them. So we needed strategies when we delivered bad news. And I have to say that we haven't evaluated what we've done. So we're still not quite sure of the extent of what this has happened. And I've just noted the time and I'm running way behind time. I'm going to have to clean it. I'll have to speed up. So our initial 1.5 hour visit face-to-face, booking in visit, I'm not sure if you do that in basically, it's a visit that's separated into two components. We do a lengthy screening assessment on all women. We screen them for risks for psychosocial vulnerabilities, for domestic and family violence, for venous thromboembolism. We talk about care planning and give them lots of advice. We pretty much changed this overnight from a 1.5 hour face-to-face visit to a telephone appointment, which was cut right back to 1 hour. And then we brought them in for a face-to-face visit for 15 minutes at 20 weeks pregnant. So this reduced the length of time that they spent with a care provider, and it presented a lot of challenges for midwives who found it very difficult to form relationships with women over the phone, and who found it very impersonal. So where am I up to? Sorry. So screening and labour and birth. Each hospital had to have screening and processes and designated wards for COVID during the pandemic. All women are screened in labour before they come into hospital. So they are either screened over the phone, or we brought them into a separate area to screen them so that we could direct them to a green, orange or red zone. As I said, we limited the number of support people. So women were allowed to have one person with them in labour. Usually that was their partner. If they were COVID positive, they couldn't bring anyone because their partner was considered a close contact. So that was very challenging for us. Until Australia refined their case definition criteria, many people were treated as suspected, even if they had mild respiratory symptoms. And this was a huge problem for staff whose common sense told them that women were probably fine. This has relieved somewhat with the new rapid testing, but it does have its problems. It's expensive and it's not available in many of the rural communities. We've received a number of complaints for women during this time. Women occasionally employ doulas to come with them in labour, and they could either have their doula or their partner, and they found this very challenging. So I won't go through all the rest of it because I'm going to speed up a little bit. Yeah, I won't go through that. So basically, if they were suspected or confirmed in labour, it affected their choices again, something that's important to women-centred care. So we have Newcastle has a home birth program for low-risk women and an off-site midwifery-led birthing unit that's quite popular. But anyone who's suspected or confirmed was not allowed to birth off-site. Midwives were only allowed to stay in the room for a maximum of 2 hours at any time, which meant that we had to have runners available to pass equipment in and out of the room. We found it very difficult as a community practice to agree on the advice around Entonox, so nitrous oxide, and eventually decided as a group that we would risk assess that on an individualised basis. So we encourage women to consider an early epidural if they were suspected or confirmed, because it was associated with a higher incidence of caesarean section, particularly if they had respiratory problems. And I've included there the community practice of New South Wales advice about care in labour for you to have a look at that later. So the newborn care, we educated women on the risks of transmission, encourage any woman that was suspected or confirmed to wear a face mask when they're feeding their baby, wash their hands and keep their bassinet about 1.5 metres away. After a lot of debate, we agreed on skin-to-skin contact at birth, and we just encouraged people to wipe the chest and the mother's chest and abdomen before placing the babies on the mother's chest. If mother and baby are well, even though they were suspected or confirmed, we encouraged rooming in, but if the babies were only tested if they were unwell. So Unwell babies are separated from the woman and partner until discharge. So if a baby went to the nursery and the mother was suspected or confirmed, she was not allowed contact with the baby in the nursery, and nor was the partner. And we found this very challenging, and it took quite a lot of negotiating with the nursery, and it's never really sat comfortably with me. Breastfeeding is recommended now, but in the beginning there was a lot of hyperbole about breastfeeding. But breastfeeding is recommended. The benefits do outweigh the risks, and we recommend expressing, of course, if the mother and baby are separated. So what we did with postnatal care was we redirected postnatal care from the hospital to the community. So we wanted early discharge, and many women went straight home from the birth suite, and we sent midwives out to do visits in the community. So all women were risk assessed before they went home, and we cut postnatal care right back down to the what we considered the essential elements. So immunisations, anti-D, vitamin K, a physical assessment, the Guthrie, the hearing and cardiac screening. It's there for you to have a look at. But everything else pretty much was cut out. And there's the guidance on postnatal care. So parent education is a core component of maternity services in Australia and has been for decades. Most women and their partners will attend parent education before their first baby. But the introduction of social distancing measures in March pretty much resulted in closure of face-to-face childbirth and parenting education programs overnight. And this was a huge concern for women in maternity services at a time when concerns about the impact of COVID had already increased women's need for information. So within a week of closing our face-to-face programs, our childbirth and parenting education network set up online sessions available to all women across our district. So at the peak of our restrictions, we were conducting 9 sessions a week across the district for labour and birth, newborn baby care and breastfeeding. So our educators basically condensed a 12-hour program into 4.5 hours, and this included opportunities for women to ask questions about COVID. So we had over 885 bookings in 2.5 months, and that just shows how important or how women seeking information was. It was a very important strategy for us to put those courses together. So what can I say about the impact on women and maternity care? Despite the fact that we've had very little spread of disease in New South Wales and Australia, we do know that COVID-19 has impacted on women's health and well-being, particularly their mental health. We've had about 5,000 babies born in Hunter, New England since this started. The impact of changes on pregnant women and families has been significant. Many women have concerns about having their antenatal appointments cut down to the essential elements, particularly multi-gravid women who are used to having 7 to 10 visits. Cutting it down to 4 face-to-face visits was quite concerning for them. Women were mostly required to attend their appointments on their own. Clinicians reported the negative impact on mental health. Women were worried about the potential risks of contracting the virus in pregnancy, the risk to them and their unborn baby. And there's been concern about potential for transmission when attending hospital appointments for antenatal care and birth. So we have had a 3-fold increase in the requests for home births over the last 3 months. So whereas it wasn't as popular as home birth wasn't as popular as we'd like it to be, in COVID, a lot more women are trying to access it. So there's been many women who are facing financial distress because their partners and they aren't working. As I said, we've had an increase in domestic and family violence reporting. And the importance of support people at the beginning of life is just as important as it is at the end of life. Most women rely on the support of their partners and families during labour and birth and in the early postnatal period. So the restriction on visitors has created an enormous amount of anxiety for women and their families. And as I said, it resulted in a number of complaints. So providing women-centred care is underpinned by good communication between health professionals and women. We worked very hard to maintain communication channels with women, and we have a Hunter New England consumer website where we put a lot of links to resources for women, and that was quite popular. We also have a Hunter New England Facebook page, a district-wide Facebook page, and this was a great resource for us to be able to put information for women and their families to access about COVID. And you can see some of the examples there. So if there's something we wanted to tell women, like the changes to the parenting education, we would post it on Facebook, and that got quite a lot of shares. So very quickly, before finishing, I'll touch on some of our COVID stats. Again, Australia itself has 25 million people, which is 1/5 of your population in Java. We've been very lucky. Our public health strategies have been very successful in limiting the spread, particularly in the first wave. Victoria has been the hardest hit and is only just recovering from the second wave now. You can see that New South Wales, which is our most populated state, has the second highest number of cases, but only 7 deaths so far, but this was a month ago. Today's figures, well, a month ago's figures, sorry, you can see that Hunter New England had no cases a month ago. That's that big wide area there, and it still has no cases. Hunter New England has done very well. So data on pregnant women, this is my last slide. So between January and the 24th of August, we had 26 pregnant women who'd been diagnosed with COVID-19 in New South Wales. This presents only a very small portion of new COVID-19 cases. None of these women were Aboriginal. 8 women were in their first trimester, 9 in their second trimester, and 9 in their third trimester. Of the 26 cases, 8 most likely acquired their infection overseas, and the remaining 18 acquired their infection locally in New South Wales. Of the 26 cases, 25 reported having symptoms. Most symptoms that pregnant women reported were mild, and there have been no deaths of pregnant women or babies in New South Wales or Australia for that matter since the start of the pandemic. So I would attribute our success not just to our small population and our large spread of our population over a large country, but also to our public health measures. We have had a very stringent contact tracing in New South Wales. You can't go into a cafe or a shop or a restaurant without signing in when you entered and when you left, so that public health services can contact anyone that's been in an area where a person with known COVID has been. So we've had very stringent public health measures, social distancing measures, and lots of public health campaigns about hand washing and avoiding public places and getting tested if you have symptoms. So that is all for me. I've got a little bit about how to access our guidance there for you if you want. And I was going to take some questions, but I've gone way over time. I'm very sorry. Sorry.
Yes, thank you. Thank you so much, Mandy, and also the last slide with some links that about guidance. Teman-teman mungkin nanti bisa dicek ya, para peserta bisa dicek karena nanti akan dikirimkan ke email para peserta, jadi bisa belajar lagi gitu. Sangat dipahami karena ini dalam bahasa Inggris, because this is in English. Jadi ada mungkin beberapa term atau penjelasan yang kurang dipahami. Tapi tadi presentasinya sangat jelas menurut saya, Bapak Ibu. So don't forget to post your comments and questions in the YouTube on your YouTube channel comment, and also on the Zoom on the chat box. Nanti akan dipilih 3 questions will be selected by committee and then will be addressed to our speakers here. So I think we are running out of time a little bit, so I just want to save 2 minutes For our next speaker, the last but not the least, our third speaker come from our own land. Selamat siang, Ibu Laurencia Lawintono.
Selamat siang juga, terima kasih.
Iya, Ibu.
Sudah diizinkan hadir.
Terima kasih, Bu. Apa kabar, Ibu?
Baik-baik saja, sehat.
Sehat ya. Sehat itu yang penting ya, Bu ya, hari-hari ini.
Iya.
Masih itu sangat berharga, kita sehat gitu ya. So, friends, as some of us know, Ibu Laurencia adalah dosen D3 Kebidanan STIK. Kita bisa lihat di screen beberapa CV beliau. Dan sekarang beliau adalah pengurus pusat dalam divisi advokasi IB dan hubungan luar negeri. Beliau menyelesaikan pendidikan formal terakhir dari Master in Advanced Midwifery Practice, University of Surrey, Guildford, UK. Dengan semua pengalaman kerja di bidang kebidanan ini, beliau banyak memberi kontribusi terutama dalam penulisan buku kebidanan juga dan kesehatan ibu dan anak. Salah satunya adalah Handbook for Maternal Services in Primary and Secondary Health Facilities, atau di buku saku pelayanan kesehatan ibu di fasilitas kesehatan dasar dan rujukan, WHO, Kementerian Kesehatan, kerjasama dengan POGI dan IBI, tahun 2013, edisi pertama ya, edisi Juni. So today she will be presenting role of midwife in normal natural childbirth in new normal era. Ibu Laurencia sudah siap-siap dengan presentasinya?
Ya.
Sudah siap, Bu? Ya, waktunya 30 menit, Bu, untuk presentasi. Silahkan, Ibu, bisa dimulai.
30 menit ya, terima kasih. Saya sudah share screen-nya. Kira-kira sudah sampai belum? Udah terlihat belum? Screen saya?
Iya, Bu, terlihat jelas.
Terlihat jelas ya. Oke,
Iya.
Selamat siang ya. Ini sudah jam berapa? Masih good morning everybody. Ya. Ini Indonesia, Jakarta, ya. Tangerang, Banten, West Java is the morning ya, before 12 o'clock. Ya. Actually, I want to thanks Ibu Maudi, juga Bapak Yayasannya, Dr. Ong, Ibu Rumi, Ibu Erna, panitia semua dari Civita Akademika Akbid. Yeah, thanks for inviting me and allow me to join this webinar. Hopefully, I can share what I know about the information of IB or IMA, Indonesian Midwife Association, because I am part of the member of the board in Midwife Association. This is nice to share with you, our international colleague. Maybe if there are some participants, I would like to share and let you know about our Indonesian Midwife Association. Actually, we have a long story. Even the midwifery school is already started since the VOC or the Dutch area in 1859 already have the school of midwife, but at the time it's already 3 years. It's no woman want to join the school because the culture, the condition, the midwife actually at the time it's home birth, they have to go out at night, and until what is our republic time, 1952, we have formal midwife education. Our Midwife Association is founded in 1951. It is just 6 years after our republic was born. And we already joined the ICM, become the member since the 1956. And also at the same time, we are also enrolled and involved in the Indonesian National Women Council. And we are the member of number 13. Since now, we also part of the Indonesian National Women Council, even usually the Secretary General is from IB. And it is also, we are part of COWANI, in our Indonesian midwife definition, Indonesian midwife should be a woman. Is it many protests, the gender issue, or from the government, the MOS, they want to change that definition, but EB still stick to the definition, Indonesian midwife should be a woman because we are part of the Kowani. Legally also, we are already registered in the government as the NGO. Yeah, this is in the 1954. Yeah, and about our organization, we have we call it central board, or usually people call it headquarters. In our policy, it should be posted in the capital city of Republic of Indonesia. If it is moved to Kalimantan, we might move our office too. And in every province, we have the province level. In all provinces, we have 34 province level of midwife written there. And also in the what is the district or city is led by the major or bupati. In Indonesia, all we have 514, and in EB have 511, almost all. It's just the new developed, new separated district, kabupaten. We have not from our EB there, but almost in every area. And also in the sub-district, we call it kecamatan, or the institution, school, or hospital, or this is the other service. If they have member of midwife, more than 15 or 15, they can form their sub-branches. And we have the, what is the sub-branches, more than 3,000. And in Indonesia also, our health policy, the midwife can practice privately. Yeah, we have, this is registered in January, have the formal, the member card is more than 314. It is more and more because some they are new graduate, they have not registered yet. And also registers for the licensing in the legal practice, more than 600,000. Yeah, this is last, what is 2018. And this is more and more. And we have the practice, private practice in Indonesia. The midwife can have their own practice privately, autonomy, yeah, almost 14,000. And in this pandemic area, many of them is closed. This is many reasons. Some because they themselves are convicted, or they are in the red zone area, or their family have the disease, or even their family not allow them to practice. And some, sadly, they cannot afford to buy the PPE, or the patient cannot pay the PPE. And total population in Indonesia in last August, 268 million more. This is, and every year the politician said it is almost 5 million, but every year. And this pandemic area, there are lots of unmet family planning issues will be more. This is more than the population of all population in Singapore. Now, this is Indonesia. Yeah. We have 34 provinces, more than 17,000 islands around there. This is sometimes 100 years. Yeah, it's just some they are still not conflicted by the COVID. It's almost all already around 500 already have COVID there. And to Miss Mandy, we also have well here. The people from the Flores entity, annually they have their traditional to hunting well. This is for their protein sources in Indonesia, in Flores. Ya, jadi Flores mereka itu berburu ikan paus ya untuk sumber protein. The webinar asked me to talk about the normal childbirth, but actually I just want to remind all of us that midwife coverage not only in the delivery. Yeah, we remind what is the definition of the ICM. Yeah, midwife is a person. Globally, this is a person. Listen, but the definition in Indonesia, we define midwife is a woman who has successfully completed the midwife education, and this should be recognized in the country, and in Indonesia have to be recognized, the register, and they have based on the possess the ICM essential competency for basic midwife practice. And the framework of the global ICM standard, we already adapt to this standard in education and practice, and HEX require the qualification to be registered and use the title of midwife and demonstrate in the competency of the practice of midwife. Now, the midwife is also accountable, the professional who work in partnership with women. But we are not the superior, and also give them the support, care during pregnancy, labor, postpartum period, and to conduct birth on the midwife own responsibility. Because some people or some profession, they still think midwife is the mandate, what is the delegation or to deliver the baby. But actually in ICM or Indonesian legislation, midwife have the autonomy to conduct but not on their own responsibility. Also to care for the newborn and the infant, include the preventive measure, the promotion of normal birth, and the detection of complication in mother and child, and also assessing the medical care, advice, and help, and also other appropriate assistance, and also carrying out the emergency measure, because in midwife, if it, the blooding and some preventable, some even cannot be like predicted. The midwife have to have the competency to carry out the emergency measure and to refer it safely. Also, the midwifery have the important task in health counseling and education, health education, not just for the woman, but also for the family and the community. Because the childbirth is the social event, not just the family. Some, especially in Indonesia, the whole period, even in international, like the princess or the, what is, some important politician, they just have pregnant, the whole world already know. The journalists announce it, what is discussed it. This what should be informed antenatal education and preparation for the parenthood, and also extend to the woman health and sexual health, and also the reproductive health and child care. Midwife practice in any setting. In Indonesia, we certainly have the home birth, and also can work in the health center, private clinic, and also in the referral hospital, even for the top referral. This is the ICM definition due to 2017, but this is not change. I know it is in 18 in Prague. It's not change for this definition. Actually, sometimes people is dissatisfied by what it is made for, what it midwifery. Midwifery, the adjective of the midwife is who is differ, what is related to midwife. Jadi the Rinfru, she is the UK midwife, and their colleague define the midwifery is a skilled, knowledgeable, and compassionate care for the childbearing woman, newborn, infant, and family. Across the continuum from the pregnancy, birth, postpartum, and the early weeks of life. But in Indonesia, under 5 children. The core characteristic include optimizing the normal biological, psychological, social, and cultural process of reproduction and early life. Timely prevention, this is an important task of midwife. Timely prevention and manage of the complication. Early detection, consult with other and with referral to other services, respecting women individual circumstance, yeah, because it's a lot of cultural and belief what is affect the childbearing process. Individual and feel and working partnership in women to strengthen the woman's own capability and also for themselves and the family. This is empowerment is one of the important tasks in midwifery practice. In Indonesia, luckily, it's thankful, we struggle for almost 2 decades to have our own regulation for midwifery, because before this is like feel as part of the nursing or part of the other healthcare, but actually, sorry, I have to. We have the Indonesian Act that passed in last year in 2019. Midwife is an issue. It is defined in this act. Midwifery is the issue that's related to midwife, considering the activity in caring with a woman at the period of pregnancy, before pregnancy, labor and delivery, postpartum, newborn, infant. This is in Indonesia. We also cover it in under 5 and preschool children. This is more promotion, yeah, and what is the monitoring of their growth and development, including women reproductive health and family planning, appropriate their assignment and authority. This is the Indonesian term in Indonesia. In Indonesia, maybe our what is coverage in more than other country, especially in the family planning. Yeah. Also, the Indonesia, in implementing our midwifery care, we should base on the humanity, scientific value. This is important in our preparation, education, ethics and professionalism, benefit or beneficial, do not harm, justice, protection, and also patient safety. And client safety. Actually, I also said this is also the provider safety, the midwife themselves safety have to be considered. Also, in Indonesia, in our midwifery act, we like also maintain about the practice, have the responsibility in maternal health, child health, woman reproductive health and family planning, executing duty based on the delicate test, because it's some like in the different in the developing country. In some area they are limited, OBGY or other expert in the healthcare. They have some delegate task or mandate, we call it maybe task shifting. Also executing based on the limited condition. Like Miss Mandy, they have the helicopter, also in Canada. In Indonesia, we have in like the remote area, we still have the very, very remote area with limited resources or limited transportation. Sometimes they take hours, even day. In some island, even maybe 2 weeks, they cannot go anywhere because of the weather, because of the what is the limitation of the transportation. In that area, also the government and EB have a special regulation for them, but they have to be prepared and not formally delegated. They have their authority and the safety of themselves to provide that care, because some is like they are not well prepared when they are just like work in the city or in the developed area. in Midwifery Act also, this is our profile. Yeah, midwives, this is a provider. They have the give information, early detection, support, empower women in reproductive right, and also the guidance. Yeah, also the delivery, the midwifery care, educator, yeah, mentoring, facilitator, also the what is elucidation, just like now, counselor, lots of misinformation, misleading, yeah, about the COVID, about what is the nutrition, is may have golden standard. Midwife have to give them the elucidation. Also, care manager in some area, they are in the district area or in hospital, they are the care manager. Also, community leader, this is important task. In Indonesia, the midwife education, we already have the secondary, the postgraduate, master degree, even now is preparation for the doctor degree in midwifery practice. This is the midwifery care, and actually have to be autonomous and also collaborative, and in certain area we have to referral in appropriate time and appropriate what is condition. Now, when we refer to WHO reproductive health, this is the 12 pillar. The first in the woman status, because the illiteration, the poverty is affect the reproductive health. Also the maternal death and maternal health and child health. Maternal care, family planning, also fertility management for the what is the fertile age, the adolescent. Nutrition also affect the reproductive health, infant and child care, prevent and treatment or reproductive infection, included HIV, AIDS, now is COVID, management of adolescent fertility, menopause, malignancy, reproductive problem. In Indonesia, midwife involved in many IFA, this is infection for the vaginal infection. This is the early detection of cancer, cervical cancer. Also the what is the breast cancer, infertility. This is limited. Maybe we refer or may have some information. Abortion care for them to have access for the family planning. And also reproductive health that related to environment and occupation. Because some occupation, some environment also affected their infertility or their reproductive health. But in Indonesian midwife, we like divide the competency in the woman life cycle, newborn, infant, under 5, preschool, adolescent, reproductive health, pregnancy, labor and delivery, postpartum, post-abortion care, postpartum, fertility age, in between. This is for the malignancy, for the detection of the non-communicable disease, for the malignancy, family planning, climacterium, reproductive sexuality health. Also the essential clinical practice, like insert IV or provide the medication, the infusion, etc. Now, in preparing the midwife and to maintain their competency to the high quality of midwifery care, we divided the competency area, the ethical and legal issue, also the patient safety. Effective communication, this is very important for the midwife, have the communication with the woman. Also personal development and professionalism. They have to maintain their knowledge, their ability, their new skill to maintain their competency. Also scientific based midwifery practice, the evidence based. Now this is many new evidence. Also clinic competency in midwifery care services. This is also dynamic. It's develop new device, new knowledge, new finding. and also health promotion and counseling. This is also the management and leadership in midwifery. The COVID already affected now is 216 countries and 195 is with local transmission. In Indonesia, even they have like mutated another new virus, they said in Indonesia they may have more than 6 types of virus, the novel virus. This unprecedented time in financial, especially in health, reproductive health, social psychology, yeah, it is make a lot of pressure or frustration for all of the population in the world. Rapid evolving, yeah, sometimes we tell it is changing the policy, even the WHO, the recommendation, the MOH, yeah, this is because a new finding, not because the inconsistent, but because the new finding, new evidence, and also significant pressure on health in the general, sexual reproductive health services, and also personal life because the limitation, the what is the cross-border shutdown, lockdown, yeah, also in midwifery. Also in majority school across the public school, also the healthcare school, working and learning from home. This is also a lot of pressure in this issue. Many private midwife practice close. Some they have their telecounseling, telemedicine. In its some is in the very what is the simple. They just use the SMS, the WhatsApp chat, or other social media, Facebook, Instagram, and also anxiety, insecurity regarding the health services and education program. This is a lot of pressure. We have to adapt to that. Now, also, this is the COVID-19 impact in all aspects of human life. Employment, a lot of unemployed, yeah. Emotional well-being, a lot of what is the domestic violence, yeah, violence in the society, criminal, economic, the new recommendation from the diabetes, no recommended lockdown. They said it's damage the economic, the financial system in the country. And one of the certainty of the lockdown, the positive, is the increase in poverty. Many malnutrition, maybe next year, maybe baby boom. Yeah, this damage the, in the past, they forced the country to lock down. Now they said, no need to lock down because lockdown is damage all the aspect. Also agriculture, but in Indonesia also they develop the agriculture. This is have the positive in the rural area, the agriculture is developing. Also the energy, this is, what's it? Maybe safe in energy because the public, the what is the factory, the mall is closed, they save the electricity, energy, especially in health. This is the World Bank information. Yeah, more than 1.6 billion children and adolescents drop out from the school, and 80%. It is the number 80% of the whole university registered in over the world. Also, this is like concern academic freedom and scientific autonomy. Also, at least at the in this pandemic area. This from the European university. Even some way we know the news is some scientists is like mysteriously killed in the developed country. This is the latest update in global just 2 days ago. Indonesia, this positive confirmed more than 300,000. Yeah, recovery is more than 79%, almost 80%. This is better, what is, but then the global died. Also, this is already better than the global rate. This is update, the WHO update in August. This is update just 2 days ago in the Indonesia. Now, in the covered area, unmet need in healthcare, this is increased because many people, they concern not to visit the healthcare facilities. Some the facilities is closed because they are lack of PPA, lack of the care provider. They're infected, they are isolated, they have their recovery process. Family planning service, they are decreased. In the WHO, UNFPA report, this is a big concern in this unmet need in health and family planning. This is expected next year. We have the coming baby boom, and it might be unwanted child or unplanned unwanted child. It have the physical or psychological impact in the long term. It will increase malnutrition, increase stunting. Indonesians think have the major what is the problem in stunting. This is maybe more and more. Also the preventable disease, because many people just ignore or they are not visit their health facility, like ignore their routine or schedule control. Also immunization. Many mothers, they don't want to bring their children to the healthcare facility for immunization. And non-communicable disease, it might increase because this area. This is the data from our family planning BKKBN. Just the first 3 semesters is already decreased. It already maternal child, it will impact the quality in maternal and child health because the pandemic is all the decrease in this coverage in Indonesia. Now, for the midwife, because this pandemic, they already have some adaptation to the practice. They already have the social distancing, have the tele or counseling. They use the handphone. They give them the form to fill in, or may have some conversation when they have to have the visit. This is before. This is crowded. This is in the midwife practice clinics. Now they change, have the distancing, have put on the mask, hand washing. This is obligation for the midwife when they to open or have their practice. They have to provide this. Also, they have to provide or have the face mask for the woman patient. Now, also they have the test, just like in the developed country, in the hospital, they have the more complete. But in the practice midwife, they have the blood test, yeah, hemoglobin, blood group, protein, urine or the urine analysis, blood sugar test, fasting or immediate, or for the hepatitis B, yeah, VCT, the voluntary counseling test. And now it provide the initiating counseling test also for the syphilis or the blood practice. Now, this is, they are required to fill in the self-assessment before they go to the health facility for the midwife. This is a list. When they answer, have them answer their own question. Have they out of home or go to the public area, market, health facility, crowd or mob, or when the public vehicle, bus, train. In Indonesia, we know this is very crowded. Even when the limitation also still crowded. And out of town, go abroad, they have to have the swab test now. And also involved in activity with many people. If yes, the score is 1. If they have close contact with the COVID-19 confirmed people, or second conversation, close conversation, stay in one room or one house. This is the score is 5. Or they have any fever, cough, or flu-like, sore throat, yeah, short of breath, it's the score is 5. When they have 1 to 4, this is mild risk. Is one of this, it's 5, is high risk. The private midwife is not take the high risk, the 5 score patient. Or if they have any comorbid disease, this is before they go to the midwife or the health facility, they have to fill in this question, and they send, and they have the appointment when they have to come to reduce the waiting time or the contact with other people. They have the temperature check for the midwife, for the patient in the midwife. Now, in the EB, for the midwife services, we divide to pre-services, when the service, and post-services. Before they have only or had consultation or education, they may by the Facebook or by handphone, or some now in by the Zoom, or the seminar. They have appointment, it's appropriate, based on via phone, SMS, comprehensive assessment, standard of care, they give them, yeah, and probing information related to COVID, also other complaint, screening risk factor for COVID and other, or suspect close contact. This is pre-service, they have to ask this question, and they have the appointment when they have to come to the clinic. When they have to come to the clinic, if they have to put on the protocol, mask, or the face shield, wash hand, yeah, verified comprehensive, the assessment result, information obtained informed consent, and also the screening risk factor, immediate referral if this is needed, and PPA as appropriate. This is a problem in some area. This is because they are very expensive. Standard service, they have to provide standard service. Also apply the COVID-19 prevention protocol, yeah, and counseling, education, information related to nutrition, early breastfeeding, initiation, and also family planning, healthy lifestyle, we call it PHBS, perilaku hidup bersih dan sehat, yeah, and also COVID prevention mission. Also, this is the pregnancy or delivery planning program in Indonesia, P4K. And limited patient supporting company also 1%. If they are in delivery or in labor, they can be support company limited to 1%. In the past, maybe 5, or in the past, may the whole family, they may come to the clinic. Now they limit it to 1%. The healthcare provider team also apply the COVID-19 just for the delivery. It's like the aerosol contact, they have to put on the 95N. And also have the post-services, the postnatal care, the post-newborn visit care by midwife. Midwife have the home visit, or they come to the midwife. Also, they continue by self-monitoring and assessment by their own, the family. The midwife guide them to use this book. This is the maternal and child health guidebook. This is very good. It's from the Japanese original, now already have in the 35 countries. And in Indonesia, we have the new edition, the 2020, just last January, but not already print in the hard copy, but already have the soft copy. It's already what is the revision, and also to adapt it to the COVID-19 situation. Any complaint, danger, symptom, immediate visit midwife with appointment, or they have to come to the health facility, but with appointment. Because we are advise them not just come, because sometimes the clinic is closed, the health facility is closed, or many people, they limited. Yeah, they have to have the appointment. Online counseling, or midwife have to teach them to use this book or other guiding book. Yeah. Also teach the ANC prenatal exercise can be by what is the Skype or YouTube or other. And also we advise the midwife to have the list of help resources, the phone or link, how to call or where to refer. The midwife should provide the respect for the midwifery care. We ask them to building rapport, trust, network, yeah, have the anticipatory guidance, yeah. And all them should follow the government MOS or COVID task force self-advice and guidance. We already have. I think this is almost the same way adopt and adapt to the WHO, like the previous speaker already talked about this a lot. Now, this is, I already mentioned before, this is the self-assessment. Even for the provider, the midwife also, before they go to the healthcare facility, the area, they have to have this assessment. Also the woman, the patient, they have to do assessment. Now, in the practice, we like work together with the OBGY Society, Indonesia Society, and the Pediatric Society. We adapt to their standard. In the pregnant area, antenatal, we limited to the physical physics. If they have this complaint, they need to go to the health facility. Otherwise, they just have the teleconference or teleconsultation. But we have to help them to, like in the first semester, if there are any contraction, any bleeding, and when the second trimester, at their movement, the develop, maybe they can observe their weight gain, and in the third semester, they have to look at the kick count, and they have to visit at least one in the second semester, and at the third semester, maybe twice, and then they have to have their plan, where to go, who company, who provide the care. This is what is the standard for the woman in the pandemic area. And also for the child health, this is the pediatrician guide. They also advise not to visit the health facility. At least they have this complaint. For the immunization, they have to have, at least they have the, what is the limitation, or they have the complication. At most, they can delay or postpone the immunization for 2 weeks. This is the advice of the Indonesian pediatrician. And we have a lot of guidebook in the MOS, also the family planning. This is the child health, the maternal health, also for the immunization. This is a picture of our colleague. This is a private midwife. They also give the, what is family planning, insert implant, cannot be distant, then they have to put on the mask. Some, if they are available, they are advised to put on the N95 mask. In the delivery in Indonesia, we have the private clinic. We advise them to use the birthing chamber. This is not recommended by WHO, but in Indonesia they use birthing chamber. This is can by plastic, because in the secondary stage, the woman is a lot of pain. Maybe they have screaming, or it consider may have the aerosol infection for the transmission for the healthcare provider, for the midwife. That's why they have the birthing chamber is by plastic, and just for the second set of delivery.
Ibu Lawrence ya, I'm so
Ada
sorry.
berapa menit lagi?
For 2 minutes, please, because
Oh,
we're
2
running
minutes. Now, this is all
late.
the,
I'm sorry.
yeah, actually, I asked before that. This is what is the impact we have delayed the immunization before the hepatitis. Yeah, what was it? Maybe premature. That's have a lot of impact in the long term for the children. This is the recommendation from the what is UNFPA. This is advised to invest in midwifery education, midwifery practice, because if they are educated well, regulated way, almost 87% of the essential care from the home can be provided. And also they have the good effect for the family and have the what is investment result. This is the admission from the what is the Secretary General of United Nations. If the midwife is educated well, they have the standard, or they have the well practice. It might have might have the better word for all, because they provide the standard care for the woman almost 90%, 87% of the essential care can be provided. That's why we are admitted, we are struggle, midwife should be well prepared, educated, trained before they become a midwife. After, they have to be trained, maintain their competency and knowledge, have be well regulated. Also, now we have our Midwifery Act authorized, to equip them to provide quality care. We have to have this equipment for equip the midwife to have the high quality of practice. Now, this is what is the unsigned expert already remind us. To the condition like this is not the most strongest and intelligent them way to survive, but this is the one they have respond to the chance. And said, what is the criteria or the intelligence if the ability to change. That's why we have to change. We said this very strong, the unsigned animal, they are already extinct. But the COVID, they keep changing. This is the latest that they said that is 10 times in the lab, they are 10 times more contagious, separated, but we don't know in people. In this situation like we are in the turn in the curve. This is very dangerous, but this is also opportunity. They may passing by, they may speed up. In Chinese character, now we are in the condition of crisis. As in Canada, is danger. We have to be careful. We have to adaptive. We have to change, and this is also the opportunity. Just like today, even this is opportunity. We can contact with Miss Mandy and also Miss Chiu from Malaysia, and in Indonesia, a lot of event, international event. This like because this pandemic area, they are pushed to share our experience, our knowledge to have more better care for the woman and for the society. Thank you. Mudah-mudahan tidak lebih waktunya ya. Terima kasih.
Ibu Laurencia, terima kasih banyak. Thank you so much for the presentation. Mungkin Bapak Ibu juga yang join, semua peserta. Saya sendiri bisa belajar banyak. I myself learned so much from all the presentations. And I believe all our attendees here join in this webinar also learn so much. Without further ado, again, so because we're running a bit late, for 40 to 45 minutes, we will have Q&A sessions. I have some questions here. Several questions, like 3 questions selected by committee. It will address to one speaker. If we have some time left later, we will go to another questions. One or two questions, it can be for all speakers, as that's also been questioned for other speakers. So I accumulate one for one. So that's just one or two questions. So ya, Bapak Ibu, kita akan masuk ke Q&A. Saya ingatkan lagi bahwa nanti bahannya akan dikirimkan dan recordingnya bisa dilihat nanti di YouTube kembali untuk pembelajaran yang lebih lanjut ya. So for our first speaker, Puan Kunlai Chu. So our first question here is a mother with postpartum tested positive COVID. Is it allowed that the baby also join care with her? So is that allowed? So what is the protocols there?
Hi. So your question is talking about if, let's say, the mom is actually COVID-19 positive, so whether the child can be with the mother. Usually we will separate them for the time being because we would monitor the baby as well, but the mom is actually considered to be positive, means we will actually monitor the baby in a separate area. Then we will do the swab for the baby, like what the explanation earlier on was talking about. We have to see within 72 hours, 2 consecutive swab. It is negative. This baby will be separate from the mom, and the mom also need to do the swab as well. Because we would like not to, how do you say? That means the mom is positive. We would not. The baby may not be positive, may not be. So we want to separate them until both are negative, then they can be together. This is how we deal with that. Yeah.
Could I say what we do in Australia?
Oh, please, Mandy. Thank you. Thank you. Yes.
Okay, so it's dependent on symptoms in Australia. So a mother who is COVID positive, who is well, essentially has mild symptoms, we would not separate her from her baby. If she's able to care for her baby, we would encourage her to care for her baby. We would ask her to use a mask when she's feeding her baby or handling her baby, to wash her hands. We'd leave the cot 1.5 meters from her bed, and we would also encourage her to continue to breastfeed. Likewise, when the baby's born, we will wash the mother's stomach down and put baby skin to skin with a mask on the mother, because we know about all the benefits of skin to skin contact and breastfeeding. So it's dependent on symptoms. If the woman is unwell, yes, we will separate her baby from her baby.
Thank you so much, Mandy. I think I just missed to add some information here. So the question, pertanyaannya Bapak Ibu itu datang dari Sukma Anggraini dari East Kalimantan. Ya tadi pertanyaan itu. Jadi untuk memastikan kita mengerti pertanyaannya tadi adalah ibu dengan postpartum ini tested positif. Kira-kira bayinya boleh nggak dirawat gabung gitu ya. Jadi ada dua jawaban dari Mandy dan Puan Kunlai tadi, bahwa yang pertama lihat dulu anaknya. Jadi kalau anaknya misalnya dites sehat ya, itu dibedakan dari ibunya. Itu dari Puan Kunlai. Jadi dibedakan rawatnya. Jadi harus dites dulu bayinya karena baru postpartum ya. Kemudian dirawat keduanya. Tadi tambahan dari Mandy Hunter adalah karena ada treatment lain yang sangat berguna di awal kelahiran. Jadi pertama itu dipastikan dulu stage-nya, kalau ingat tadi ya presentasinya Mandy Hunter tadi, ada stages untuk setiap orang yang dites. Jadi ada 5 atau 4 tadi, tergantung hasil tesnya yang mana. Ya, kemudian diikuti dengan health protocols, protokol kesehatan tadi. Jadi kalau misalnya anaknya tidak positif, jadi ada health protokolnya, misalnya harus cuci, harus basuh tangan dan juga ikutin health protokol. Kemudian ketika baru lahiran, ini stomachnya, perutnya harus dibersihkan sehingga bisa skin to skin. Gitu ya. Jadi untuk inisiasi menyusu dini. Kemudian yang lain harus tetap ketika mengunjungi anaknya, mengunjungi bayinya harus tetap pakai masker dan prosedur yang lain. Gitu ya. Jadi ya mantap benar ya. Semoga kita secepatnya bisa ini ya, bisa di setiap fasilitas bisa sampai seproper itu. Thank you Mandy and Miss Puan Kunlai. The second one. And other speaker, Ibu Laurencia, you are welcome if you have something dari pertanyaan-pertanyaan itu, you're welcome also to contribute. The second one is what is the risk to be anticipated from a person or a mom infected from COVID in the delivery process? Like, is it? Do you ever have studies or observation for mother-to-child infection or mother-to-child transmission during pregnancy and also delivery process? Is the question clear? Let's start with Puan Kunlai. Is that clear, Bu? So is there possibility mother-to-child transmission from a mother tested positive? Yes.
Yeah. The mother is
it clear?
Mother.
Yes. Is it what is the risk or risk for mother child infection during pregnancy and delivery process? Maybe we already have something information. You already have something for that.
Myself, I didn't do that study, so I don't think I can give you the exact answer. Yeah.
Okay. Yeah, because this is new for us, yeah.
Yeah, it is new
yeah,
for all of us.
But this is a good question. Ibu Sukma, terima kasih buat pertanyaannya. Yeah.
But I think the basic principle will be the basic principle will be we have to practice our PPE, hand wash, and also the mask. Yeah. Then to prevent the transmission of the virus to the baby. But the actual study, I didn't study, so I cannot provide the information. Yeah.
Okay, thank you. Mandy and Ibu Laurencia, do you have addition for that?
Well, again, we have very limited experience in Australia because we have had very few positive women. However, the advice from our overseas colleagues, particularly we look to the United Kingdom and the USA when we are looking at our evidence, is that the risk of vertical transmission is very low, and that the risk of mother-to-baby transmission depends, it can be minimised by the things that we've already talked about and that my colleague just talked about, hand washing, masks, PPE, washing down the abdomen before you do skin-to-skin contact. So I can't talk from an informed background because we haven't had the experience in Australia, but that's what the evidence that we rely on from United Kingdom, the USA, and other countries as well to inform us. But certainly we would not separate a well-positive mother from her baby at birth just because we wanted to minimise the risk of transmission. We would, if the baby was symptomatic, it would go to the nursery straight away. And yes, we'd separate the baby from the mother then. But if the mother was well and the baby was asymptomatic, even though she's positive, we would keep them together. Because the risk is so low if the woman is not coughing and sneezing all over a baby and she uses good hygiene measures.
Okay, thank you, Mandy. Ibu Lawrence, do you have something for this?
Ya, saya rasa beda in Indonesia, because the question from Indonesia. Saya rasa sama ya. Jadi ini tergantung daerahnya di mana. Ya, di tiap daerah itu apa? Task force-nya, satgasnya COVID atau rumah sakit punya kebijakan. Juga tergantung dia di daerah di mana? Di daerah hijau, red zone atau green zone itu beda ya, beda-beda. Jadi kita tidak bisa samaratakan. Lebih baik jangan tanya secara nasional. Lebih baik kita konsul ke tempat ya, karena ada beberapa yang daerah terbatas, ada yang bisa mungkin lebih bebas, ada yang lebih strict ya. Itu lebih baik kita konsul kepada kebijakan setempat. Karena Indonesia sangat luas ya, juga sangat berbeda. Ada yang merah, ada yang bahkan sampai daerah hitam, walaupun sekarang sudah mulai turun, masih banyak lagi yang ada. Bahkan di daerah yang dulu katanya negatif, ternyata mereka negatif karena belum dites. Begitu dites, ternyata masih positif. Jadi hati-hati. Nah, walaupun tadi sudah dikatakan, sebaiknya itu memang tidak terpisah. Kalau anaknya dengan ibunya. Biasanya kita jelaskan sejelas-jelasnya, keputusan terakhir pada ibu, ya. Toh memang sudah dia di dalam itu ibunya sudah ada close contact, ya. Juga di dalam banyak penelitian memang kelihatannya tidak ada penularan langsung dari ibu ke anak. Nah, kecuali yang tadi sudah disampaikan juga Miss Fanny, kalau ibunya batuk-batuk atau ada gejala panas, tentu ini situasinya lain. Saya rasa jawabannya lebih baik kita kondisinya masing-masing dan tempatnya masing-masing. Tidak bisa kita samaratakan ya, untuk semua tempat itu sama. Saya rasa sedemikian aja. Terima kasih.
Iya, makasih Bu Laurencia. Teman-teman peserta, seperti yang dijelaskan tadi oleh Puan Kun, bahwa belum ada, karena ini baru, jadi belum ada pelajaran atau studi yang formal tentang itu, tapi kita tetap mengutamakan health protocols. Juga tadi Mandy menambahkan bahwa kita ingin meminimalisasi resiko dan juga transmisi atau infeksi dengan melakukan health protocols semuanya gitu ya. Jadi agar transmisi atau resikonya sangat-sangat rendah gitu. Teman-teman, kalau menurut saya ini membantu kita berpikir bahwa sepanjang health protocol sebenarnya kita bisa lebih termanage gitu ya, bisa lebih dikendalikan gitu. Jadi sekarang bagaimana caranya agar masyarakat kita, keluarga-keluarga, terutama ibu hamil dan akan melahirkan, bisa melakukan health protocol ini sungguh-sungguh dan konsisten gitu ya. Okay, our next questions for Puan Kunlai. This from Rofiatul Umami from West Java. Hey, that's my province. I live in the same province. How do we treat a pregnant woman with tested reactive COVID-19, but in rapid test? So must this patient isolated? If they isolated, how they get antenatal care? Do midwives visit them in the isolated room, or is there any other practices for this services for this? Is the question? Yes, let's start with one.
Thank you for the question. Okay, so if the pregnant lady is tested to be positive, so what we do is we will nurse this patient in the negative pressure room. Okay. Then we will practice isolation practice, meaning that each time you go to the patient, you have to wear your PPE, the N95, and whatever procedure you need to do for your patient, you need to protect yourself. we base on all these PPE universal precaution. Yeah. So the basic rules is we need to separate them from other people because they are infected person. So we will not mix them with other people. So we will nurse them in a single room, isolation room. Then whenever we see the patient, we have to gown up and with the PPE, appropriate PPE. This is how we give the nursing care for the patient. Yeah.
Thank you Puan Kun. Jadi para peserta tetap dikunjungin ya. Ini kan pertanyaannya apa harus memberikan visitasi? Ya, tetap harus, tapi harus memakai melakukan health protocol, terutama pakai PPE pelindung diri. Itu yang disampaikan oleh Ms. Kun. Ibu Laurencia and Mandy, do you have something for addition?
Yes, I wanted to say, again, it depends on the woman's condition. If the woman is pregnant in the community and her condition doesn't require hospitalization, so if she's one of the patients who has mild to moderate symptoms, she doesn't need to come into hospital. So if she was pregnant, what we would do is we'd advise her to self-isolate at home so that she wasn't going out and spreading it. And we would keep in phone contact with her to make sure that she wasn't getting worse and didn't need to come to hospital. And we would delay her antenatal care until she was clear, okay? So say she was 24 weeks pregnant and she was due a visit and she had COVID. We would contact her, and if she felt her baby moving and her blood, she felt fine, she didn't have any headaches or anything, we wouldn't go and see her and do an antenatal visit because her condition doesn't need it. We would delay that next visit until she was clear and we could see her. But if she got worse and needed to come to hospital, we would advise her not to delay that, and we would then see her in hospital, just like my colleague said, using all our PPE. But we would not bring her to hospital or do a visit if she didn't need it, if we could possibly delay it.
Thank you, Mandy. That's very clear. Ibu Laurencia?
Ya, lebih baik dari saya bahasa Indonesia ya, karena ini yang banyak bahasa orang Indonesia. Ya, saya rasa kalau ini kan pertanyaannya kalau ibunya self isolation ya. Nah, kalau di Indonesia biasanya ini kalau kita ada task force ya, COVID task force, ini Satgas sudah dibagi puskesmas per wilayah, regional, regional wilayah. Jadi biasanya mereka lapor dan dia dipantau. Tidak hamil saja yang ini mereka dipantau, bisa by phone. Jadi beberapa minggu lagi dia akan datang. Kalau perlu puskesmas yang datang, orang bidan atau perawatnya yang kunjungan rumah. They have home visit from the closest health center. It is assigned by the task force, COVID task force. In Indonesia we have the policy like that. Jadi the provider have the home visit to the isolated woman. Yeah. Also, they are monitored by phone or by SMS, or they send their question or answer by phone. Jadi mereka biasanya dipantau. Kalau perlu suruh periksa apa gitu baru datang. Kapan dia harus periksa ulang? When they have to repeat their test, what kind of test? Usually they are monitored by the health center. Ya, jadi biasanya juga untuk bidan praktek, kalau di sini hadirin ada praktek bidan. Kalau yang positif begitu kita jangan ambil alih lagi. Ya, serahkan saja ke puskesmas, jangan ambil resiko. Yaitu untuk penularan, untuk PPE, untuk APD kan ibu-ibu bidan harus bayar ya, is the extra cost for the PPE. That's why if the private midwife have the confirm or positive test positive patient is better, refer for the what is the task force for the health center. Jadi lebih baik kita serahkan, jangan ambil kalau pasien sudah ada positif, ya. Jadi jangan lagi ditangani. Itu punya resiko untuk pasien dan juga untuk provider, untuk bidannya sendiri. Paling sedikit ibu harus tambah ekstra APD, dan itu biaya, ya, biaya mahal. Walaupun sebenarnya IBI berusaha untuk minta bantuan karena beberapa bidan itu tutup prakteknya karena tidak mampu membeli APD karena ada yang mahal, ya, seperti N95 itu mahal sekali, dan ada bantuan di beberapa kita sudah bagikan itu lewat puskesmas, lewat Bikornya. Nah, jadi lebih baik the midwife when they have the practice, the private practice midwife have the patient is confirmed positive, this is better, refer to the assign the health center. This is the task force, dia punya duty, ya, dia duty, not the private sector duty. Ya, lebih baik ibu jangan ambil resiko. Itu saja saran saya. Terima kasih.
Okay, thank you so much, Ibu Laurencia. That's very clear. Dan itu mungkin bisa ini ya, bisa jadi panduan kita juga di lapangan gitu. Okay, so the next questions is for Mandy Hunter, but I think this question can also goes to all speakers. From Ibu Yuhana dari Sulawesi Tenggara, ya. So, what is the proper and most required information or education for pregnant mothers, pregnant ladies who get stressed due to tested positive COVID-19? So, well, this is like a story or a study that case study that before she's just pregnant, not stressed, but after get tested, either that's reactive, negative, or positive, they got stressed. So, what is the proper or most required information at that time? For all that stress. Mandy?
That's a good question. And again, we haven't had as much experience as you guys with this problem. But what we do know from the literature is that pregnant women are not more susceptible to COVID than the general population. So just being pregnant doesn't make you all of a sudden high risk. Mind you, if you have got comorbid conditions like high blood pressure or obesity or asthma and things, then you are at higher risk, just like the rest of the population. So we would try and reassure women that there's no evidence that it increases the risk to their baby. There is some evidence that it increases the risk of preterm birth slightly, but again, that would depend on where they were in their pregnancy. And we're not sure if that's because, it's a truly predisposes women to preterm labour, or if we are intervening earlier with women who have COVID in their third trimester. So reassure the woman that, there's no evidence that her baby's at higher risk. I also think that prevention is better than a cure. So my advice to any pregnant woman, and this includes pregnant staff, we put out some guidance for pregnant staff, is that once you get towards your third the real risk with COVID for a well pregnant woman is what we do to them in labour. If a pregnant woman comes in labour with COVID, she doesn't get to have a partner with her. We'll take her baby off her if she's unwell or a baby's unwell, and we'll separate her from a baby, and they're not very nice things. So my advice to pregnant women is that try everything you can to minimise your risk of contracting COVID, especially once you're in your third trimester. Don't go out if you don't need to go out. Don't make sure that you use your hand hygiene and all those things, and try and protect yourself like you're high risk. You're not high risk, but you just don't want COVID when you go into hospital to have a baby. So reassure them that there's no evidence that it'll be damaging their baby. There's minimal evidence about preterm labour, but there's no evidence that increase the adverse outcomes for babies. But try and protect themselves from getting it in third trimester, because we really don't do very nice things to pregnant women having babies with COVID. Does that answer your question?
Yes, but if you have more about some points or information or education information for their stress, anything that you want to add?
We know that any stress in pregnancy is bad for an unborn baby. We know that. Have you heard about the first 2,000 days? Have you heard about that? And the effect of health behaviours and anxiety and depression on pregnancy. We know that none of it's good. So reassuring women that, reassure them that COVID is not a death sentence for them or their baby, that, they will recover, most of them will recover from COVID without even having to go to hospital. Most of them will recover from COVID. And just keep reassuring them that they do not need to panic, and just to look after themselves. Stay hydrated. I don't know what else to say. We can't promise them that nothing bad's going to happen, but just try and allay their anxiety as much as possible. Most of them will be fine. And it's not the pregnancy that puts them at risk. It is their other conditions.
Yes. I think that's very important, Mandy. Para peserta ini hampir sama ya dengan mungkin anxiety atau stres yang dialami pada umumnya ibu hamil. Jadi tujuan kita, kalau dijelaskan oleh Mandy tadi, adalah untuk menjaga ibu hamil tidak terlalu stres atau bisa mengendalikan stresnya dengan beberapa hal, mungkin membantu. Kalau saya pikir sih ini juga membantu ya, bukan hanya untuk pregnant mom, tapi juga untuk kita orang awam, untuk menyampaikan bahwa misalnya kita terpapar COVID-19 itu bukan hukuman mati ya, it's not a death sentence gitu. Jadi panik berlebihan karena sesuatu yang bisa disembuhkan dengan semua protokol kesehatan dan treatment, karena sebenarnya data membuktikan, menunjukkan bahwa memang jauh lebih banyak yang kembali sehat. Tapi kita juga netral, tidak bilang bahwa tidak ada yang misalnya mati gitu ya, tapi kita harus fair gitu untuk memberikan informasi itu dan menjaga agar ibu hamil tetap sehat mentalnya. Yeah. Thank you, Mandy. Puan Kun, anything you want to add?
Yeah, I think I agree with you, Miss Rumi. Yeah, this is actually not the stress only for the pregnant lady, it's the stress for all of this. So I think that knowing that this can be prevented by social distancing and also your personal hygiene, mask and whatever, then we just go to that rules, then you'll never go wrong. Yeah.
Very clear, Ms. Kun. Ibu Laurencia?
Yeah, I think less like I have said before, this we can, building the trust, the rapport, let them talk. Yeah, when they have stress, this is better to have them talk to the person or the close they believe, the friend, or we have the link. We have like refer to just I said, we have the list for the help resources to whom we can refer them to. Just let them talk. And also, this is especially in Indonesia, terutama di Indonesia, a lot of misleading information. Yeah, sometimes you can like have one day you have more than 20 or 12 or advice for the nutrition for whatever. Ya, jadi kadang-kadang suruh mereka jangan buka WA, jangan buka ini. Stop the misleading information. Yeah, this is one of the also. Yeah, some people they stop their their device. Yeah, just have limited information for them and talk to somebody they believe. And yeah, that's just like Miss Mandy advice. We have to objective, but not add to the more stress. Ya, jadi beri kabar gembira, the good news we have give to them. Ya, jadi hal yang baik. Ya, jangan yang semua kalau di Indonesia kebanyakan yang negatif. Ya, negatif news. Ya, give them the good news. Also the closest health facility they can visit or they can talk to, and also report what is trust, care for them. Ya, sering ditanya, dikunjungi. Mungkin ya lagi kita ke community, ada orang yang bisa menghubungi mereka, memantau mereka. In Indonesia they have a lot of community, the neighbor, they give them, send them food, send them fruits, ya, have them help, ya, for the grocery, for the shopping, ya, jadi diberi bantuan sebisanya, ya, dengan resources yang ada. Sekali lagi di lingkungan mana, ya, banyak sekali hal positif di Indonesia dengan adanya COVID ini juga. Ada yang bagi makanan, bahkan ini ya ready to eat, ada yang memberi makanan yang sudah bisa dimakan, ya, tergantung di lingkungan mana, ya. Give them the positive, the good news. Just stop the negative, the misleading information. In Indonesia there are lots of misleading information. Ya, also the bizarre behavior. Ya, even ya, jadi banyak juga penyakit perilaku aneh yang di Indonesia mungkin di tempat lain tidak ada, ya. They take the cops from the hospital, even from the ambulance, ya, itu kan hal-hal negatif yang aneh, bizarre behavior, ya, yang mungkin karena misleading, misinformation. Jadi ya, justru bidan itu ibu-ibu yang tidak praktek, please, ya, like update your information, give the proper, what is the evidence, scientific based information. Jadi jangan misleading information, because the misleading information also give them a lot of stress, pressure. Ya, jadi itu saja. Ya, sering dipantau, dihubungkan, ada resourcesnya, ada list kemana mereka. Kadang-kadang kita tidak perlu telepon mereka sendiri, beri kaca ke salah satu badan atau organisasi yang mereka bisa bagi tugas. Oh, di daerah ini dia bisa hubung ini, atau mereka bisa memantau sendiri. Ya, terima kasih.
Terima kasih, Ibu Laurencia. Thank you so much. Friends, we got a lot of questions, but I think all of our speakers here already address your questions. Jadi pertanyaan-pertanyaan seputar edukasi, ya, seputar konseling untuk pasangan yang ingin melahirkan misalnya, yang berencana punya anak misalnya, menambah anak di musim pandemik ini, sama aja ya nasihatnya, health protocol, manage our information yang datang ke rumah dan juga yang kita terima. Jadi know what's the correct and right information. Kemudian jadi hampir sama tadi ada pertanyaan, another questions about how midwives should respond when they are asked to deliver services for COVID-19. Tadi Bu Laurencia sudah jelaskan, so should need to follow the health protocols and then need to connect or contact the Satgas in your province or in your respective areas. Jadi mungkin ada perbedaan, mungkin ada beberapa general procedures, universal procedures yang ada di lapangan. So we need to follow, we need to know that, and then we need to follow that and refer the pregnant mom who experienced that symptoms or some risk to this Satgas. The last question, I think that quite different. I know this is too soon to ask, but if you know anything about this, it's good to share with us. Is there, the question is come from, again, from region West Java, Sri Noviani. So the question is there any side effect for pregnant women with side effect from flu vaccine, or can I say this, COVID vaccine for pregnant women? I know this is too soon, but if you have a little bit or anything, but if we don't know anything now, well, we can say it. Let's start with Ibu Lawrence, ya kan? And then Mandy and Puan Kun, please.
Oh, saya duluan.
Boleh ya, Bu?
Ya, saya rasa kita jangan mendahului, benar juga kata Ibu Rumi ya. Tapi tujuannya kan baik, vaksin ya. Tapi di Indonesia hati-hati, memang kita waktu tidak COVID saja, vaksin ada yang menolak ya. Dengan ada tidak halal lah ya. Kemudian misalnya yang jadi autis, negatif-negatif, bukan hanya COVID. Before the COVID, they also a lot of concern about the vaksin, ada vaksin. Ya, jadi ambil informasi, ini COVID baru, tidak ada yang tahu, jangan mendahului, kita tidak berani mengatakan sesuatu. Ya, itu saja, tapi kita lebih baik percaya kepada ahli, ya, the expert opinion from Indonesia, from what is the WHO, from the what is the global, yeah, when they are already approved, it is already have the safe effect. But in Indonesia, especially also another concern, this is the halal, ya. Tapi sudah diperhatikan, ya. Sudah termasuk ada wakil presiden di situ, Depkes semua sudah perhatikan karena halal also a big issue in Indonesia about the vaccine, ya. Tapi efek yang untuk negatif for the health belum tahu, ya. Orang COVID-nya aja baru berapa bulan, efek kadang-kadang even the effect is like long term. Jadi supaya thalidomide itu berpuluh tahun bahkan decade kemudian juga masih ada. Tapi kita tidak mendahului. Saya rasa jangan mengada-ngada dulu. Terima kasih.
Terima kasih, Bu Lawrence. Thank you so much. Yes, that's really important for us to consider or to really what is important now. What is the first thing now? We need to prioritize that. Okay, Mandy.
Okay, sorry, I didn't understand a lot of what Lawrence just said, but I did hear the halal, which isn't as big an issue for us in Australia. In Australia, we offer every pregnant woman a flu vaccine at 28 weeks. We take it very seriously. And in fact, I think there is evidence that the flu is as bad as or if not worse. We can see worse side effects with the flu than we have so far with COVID. And likewise, we don't want women to get flu and COVID. So if we can protect against the flu, that's one thing, but we can't protect against COVID. So in Australia, every pregnant woman is offered the flu vaccine at 28 weeks gestation. There is no COVID vaccine yet. And I know from my experience with research that when it's released, it has to go through very stringent processes before it will ever be approved for use within pregnant women and people in general. So I've no doubt that when there is if and when there is an approved COVID vaccine, we will most likely we'll wait and see whether it's safe for pregnant women. But my understanding is if it's not safe to use on pregnant women, they wouldn't be using it on anyone. The risks, the side effects from the flu vaccine are no greater in pregnant women than they are in the general population. That's my understanding.
Thank you, Mandy. teman-teman para peserta untuk menyampaikan 2 hal aja yang dari ini ya, dari Mandy tadi. Kalau ini pertanyaannya lebih kepada flu vaksin, sebenarnya aman ya, karena kita sudah implementasi di sana, kata Mandy bahwa itu diberlakukan atau diberikan kepada semua ibu hamil. Tapi kalau COVID vaksin itu kan masih di dalam ini ya, penelitian, masih dalam pembuatan dan juga tes. Tapi satu hal yang poin yang penting yang disebut Mandy tadi adalah bila itu tidak aman, vaksin apapun sebenarnya bila itu tidak aman untuk ibu hamil, itu mungkin tidak aman untuk komunitas, untuk populasi yang lain. Jadi itu salah satu saya pikir poin penting, that's very important untuk kita melihat vaksin juga seperti itu. Semoga membantu ya. Miss Kun. Good luck. Yes.
Yes, we provide flu vaccine for our patient. Will be based on doctor's assessment and also doctor's prescription. It is not compulsory because there are some people they don't want to take vaccine. I mean flu vaccine. Some pregnant lady, so they will have a discussion with the doctors and also to think about what are the side effect and also based on individual situation. Then they will make a decision on that. Yeah, this is what will happen in our country here. Yes.
Yes. Thank you Puan Kon. Dari Puan Kon tadi agak berbeda praktisnya, tapi kalau untuk vaksin flu bisa diberikan tapi dengan ini ya dengan prescription dokter gitu, ada rujukannya gitu. Karena nggak semua juga penting, perlu, dan tidak semua juga mau gitu. Jadi lihat ininya ya, lihat kondisi orangnya atau ya, ibu hamilnya. Begitu untuk pertanyaan ini. I think dari question from Pak Junedi. I know I said the last, but I think this is also important. Almost same information actually. In general observation, how you suggest a family or a couple to plan their pregnancy during this COVID-19? How vulnerable for pregnant woman or delivery during pandemic? So then they know the suggestion for families. Ini untuk edukasi berarti ya para peserta ya. This is for education then. Okay. Anything? Just quick information. Let's start with.
I don't think.
Okay, Mandy.
Yeah. COVID-19 is not it shouldn't prevent people having their families. I think it's something that we can all get joy out of having a baby at a time when there's a lot of misery and in the world. So I think it would be very sad to tell a young couple to delay having a child because of COVID. Most young people are well. Most young people, especially women who have childbearing ages, will cope very well during this pandemic.
Thank you, Mandy. Puan Kon, anything?
I think it's a very interesting question, actually. Yeah.
I saw you're smiling.
I think it's like this. If let's say you want to plan for your pregnant, so you must be very alert with your environment. If let's say really you have COVID-19 infection, you just try your best, don't go there. If let's say you are pregnant, but I think family planning, how do you say? You actually can make it natural or new norm. It's actually a new norm and also a new era. I mean, we have to go along with the COVID-19. So we cannot avoid to say, oh, stop, COVID-19, only I get pregnant, no such thing, right? So if let's say you already prepare yourself and then you already think that, oh, it's a good time for you to pregnant and actually you are pregnant, then you must abide to something that you are not going to be affected yourself. For example, don't go to the crowded place, don't go to, keep distancing, that kind of things. That how you have to protect yourself and your baby. Yeah, that's about it. Yeah.
Wow, that's a good combo actually. That's a good combo. Like para what our speakers mentioned is go ahead, plan it out, follow health protocols. That's this just do natural thing even in pandemic areas. Just be cautious for what you have to do for healthy pregnancy and delivery. Ibu Laurencia, the last. Anything? Atau udah bagus dengan good combo? Bu, you have to unmute. Unmute your mic, Ibu.
Okay, sorry. Yeah. To plan, I think just before the COVID, all we just like give the objective information, the appropriate information, Yeah, this is their own decision. Yeah, decision making for the couple. Yeah, because many things we still unknown about the COVID. Yeah, long term, short term, is this keep changing the protocol also even from the WHO. Yeah, just like let them decide for themselves. Yeah, the what is the possibility of the transmission, the effect to the society for the what is they have to isolate themselves if they are convicted. Now this is many studies said this is just like already like mentioned by the previous speaker, is very few effect, direct effect or the what is the vertical transmission to the baby. Yeah, but even is still many things is unknown. Jadi let them decide for themselves. Just we give them the possibility, the transmission and the protocol. Ya, jadi sekali lagi lebih baik untuk kehamilan itu ya kan banyak hal yang perlu dipertimbangkan. Masih banyak hal yang tidak diketahui. Jadi biar mereka memutuskan sendiri. Ya.
Sendiri.
Banyak sih yang
personal.
Ya, waktu ini lebih baik menundalah jadi pada cari masalah, kecuali special because the age, the couple, because a woman sometimes also the condition of the family, ada yang sakit, ada orang tua, itu masing-masing daerahnya apa keputusannya lain. Lebih baik mereka memutuskan sendiri. Sekali lagi, we just let them decide for themselves, give them the information, the objective. Yes, still sometimes is still unknown about the COVID. Tapi yang satu hal memang that's vertical transmission very few transfer. The evidence is sedikit sekali ya, very few vertical transmission menular. Tapi efek jangka panjang kan belum tahu ya. This is, jadi biar mereka putuskan sendiri informasi yang objektif saja. Ya, sekali lagi kecuali mungkin ibunya ada batasan umurnya, ada keluarganya ada yang sakit mau cepat punya cucu, itu masing-masing punya alasan, punya their own reason. Ya, terima kasih.
Terima kasih Ibu. That's a perfect statement with perfect questions, I think, to end our Q&A sessions. I know we're running late, like 15 minutes. Thank you, our respected speakers. On behalf of all attendees here, our audience, I would like to give high appreciations and gratitude for your sharing and presentation. That's a very great information for us, and also the interaction, the questions is really beneficial for the services for midwives, and also I think for community development and for community educations, because pandemic and COVID-19 is our global problem, our global pandemic now. So it's good to learn from each other and then get the most beneficial from our learning today. Thank you so much. Jadi Bapak Ibu yang mau hamil silahkan hamil, itu keputusan pribadi, itu keputusan sendiri, tapi mengetahui informasi yang objektif, yang komplit, so you will make your best judgment to plan your family or to to have another son or another daughter in family. It's your decision, but make sure you know proper information and objective information for that. Itu mungkin yang harus disampaikan kepada keluarga-keluarga yang kita layani in counseling and health education. Thank you so much. Bless you all, Ibu Miss Kun Lau Chu, and then Ibu Laurencia, and many great things and all blessings for you. Hand over to you, Miss Erna.
Yes, thank you, Ms. Rumi Sidabutar, for the guidance of the webinar today. Hopefully, today's webinar will be of great use to us all. Kami mengingatkan kepada seluruh partisipan untuk mengisi link evaluasi yang telah dibagikan di Zoom chat room atau di description box di YouTube channel Akbid Bina Husada. Kita akan menutup link absensi dan link evaluasi pada pukul 7 waktu Indonesia bagian Barat. Dear webinar participant, the speakers have finished presenting their respective materials. And now, this webinar will be closed by the Director Akbid Bina Husada Tangerang, Dr. Maudi EU Jami, MKM MKep. Hello, Miss Maudi.
Yeah,
Good afternoon.
Yeah, good afternoon.
Miss Maudi, we would like to invite you to give a speech and officially close this webinar. Silakan Ibu Maudi.
Yeah, thank you, Miss Erna. So this is my turn now. Okay, first and foremost, I would like to thanks to God Almighty. We already finished our webinar today. Also, I would like to thanks to our respect speaker today, Bunda Mandy. Hi, Mandy. How's Newscastle there? Long time no see. You look fresh after you take your short holiday. That's good for you.
It's been lovely joining you. Thank you.
Yeah, I saw the picture on your Facebook. Thank you for helping us today. And also to Puan Kun Lai Chu from Green Eagles. Hi. When we went there, I didn't meet you. I just meet Miss Vivian and Miss Nur. But thanks God, we meet you here today. And our Bunda Laurencia, Bunda, thank you so much. Actually, she is our teacher when I went to Diploma 4 at Poltekkes Depkes Jakarta 3. Akhirnya ketemu lagi Bunda, dulu ketemunya di dalam kelas.
Long time ago.
Long time ago too. And our moderator, Mbak Rumi Sidabutar, thank you for leading our webinar today. Hi there. Actually, she is my old friends. 3 of us, Bu Erna, me, and Mbak Rumi went to postgraduate together at Indonesian University. So it's a good time to meet again. Thank you so much. Special thanks to I want to thanks to our Nur Soraya Foundation for giving us opportunity to have this webinar, and thanks to our organizing committee who have worked hard to success this event today. Actually, this webinar has been our dream for a long time, and it's finally coming through today. Praise the Lord. Last but not least, I will also thanks to our participant for your enthusiasm. That actually for the last question, it's very interesting. All of us laugh together. And also to our student of Akademi Kebidanan Bina Husada Tangerang and the alumni, thank you so much for participate on today's webinar. We have learned a lot of our speakers today by their knowledge and experience. Hopefully, all of us can enrich us to providing the better service to the public, especially for the mother and the child. We are still living through the COVID-19 pandemic. Please take good care of your health every one of us must remember to carry out strict health protocols so that this pandemic can end soon. Finally, with praise and gratitude to God Almighty, I will officially close the third series of Akbid Bina Husada Tangerang webinar today with the theme of patient and lifelong learning in Midwifery Service. May God protect and bless us all. Thank you. Back to you, Miss Erna.
Yeah, thank you, Miss Modi, for the closing speech. Oke, kepada seluruh partisipan, kami sampaikan pada siang hari ini untuk bersama-sama kita kembali mengingatkan mengisi link evaluasi dan link absensi. Before we close the webinar, let us take a photo together. Dear admin, please take the photo. Kita akan foto bersama. Saya serahkan ke admin.
All right, ladies and gentlemen, we'll take a photo session. You can put your sweetest smile on, and on the count of 3, I'll take a picture. So 1, 2, 3. All right, perfect. Next slide. 1, 2, 3. Perfect. Next slide. 1, 2, 3. That's sweet. Next slide. 1, 2, 3. Okay, another next slide. 1, 2, 3. Oh, that's a lot of participants here. We'll take a picture. 1, 2, 3. All right. Okay, 1, 2, 3. All right, perfect. Thank you so much to all participants and to our speakers, and I'll give it back to Miss Erna.
Yes, thank you, admin Sabrina. Dear webinar participants, this is the end of our session. Let me to thank you for Miss Kun Lai Chiu. We have hospital visit to Gleneagles Medini Hospital Johor Bahru in Malaysia in 2017 and 2018. The hospital is so clean, famous in Malaysia, and the staff is very friendly. Thank you, Miss Kun. Send our greetings to Miss Vivian Ching, Miss Emily Chow, who supported and dare contribute to us. God bless you, and good luck for Gleneagles Medini Hospital and to all of you. So thank you for Miss Mandy. Thank you so much. Our director, Miss Modi, have a visit to your hospital too, John Hunter Hospital, and Miss Mandy is so humble and friendly. Thank you so much, Mandy. God bless you and good luck for you. To Ibu Laurencia Lawintino, terima kasih Bunda. Ibu Laurencia ini merupakan mother ibu kebidanan di Indonesia ya, yang cukup senior dan terkenal. Kita sudah lama mendengar namanya dan beliau sangat berkontribusi pada dunia kebidanan. Semoga sehat selalu Bunda dan sukses selalu. Terima kasih sudah mau menjadi narasumber di webinar Akademi Kebidanan Bina Husada. Dan untuk sekali lagi untuk moderator kita yang ngehits hari ini yang sangat menginspirasi, terima kasih banyak untuk kontribusinya kepada webinar dan tetap menjadi pribadi yang menginspirasi. So, let's us to next. Finally, we thank you very much to all participants. Good luck, keep up the spirit, stay healthy, and please remember to follow the health protocols. We really hope the COVID-19 pandemic can be resolved soon. Thank you very much. Thank you very much. Goodbye. See you next time.
Bye.
Thank you Puan, thank you Mandy.
Thank
Terima
you
kasih
all.
banyak Bunda Loren.
Ibu Modi.
Terima kasih, Liv ya.
Terima
Thank
kasih.
you all.
Terima kasih, Liv.
Bye semuanya, mohon izin leave now ya.